Good afternoon, and welcome to the second webinar by AMR Declaration Trust. AMR Declaration Trust is a public charitable trust founded on the principles of Chennai Declaration. No option, no treatment option is a common phrase that's being used on a daily basis in academic meetings and in the media. Today, we have a team of 24 infection specialists in our country explaining us their perspectives on no option in a very simple and informal way so that the public and general medical community will have a good understanding what the no option scenario is. Public is the most important stakeholder in tackling antimicrobial resistance, and media is very important in communicating with the public. We have a session with the prominent scientists science journalists in our country as well. AMR Declaration Trust has minimal funds. We have received small donations from doctors, including our trustees. However, our resources is not adequate to conduct academic activities. We decided not to charge any registration fee to spread the message to a broader audience. Hence, we have received small unrestricted conference grants from companies such as Sanofi, Galanjan, Converge Biotech, Alniche, and requested a few other companies like Cipla, Pfizer, Sanofi to give us unrestricted educational grant. We will move on to the first session, first fireside chat session that will be chaired by Dr. Sunitha Naredi, who is a senior consultant on infectious diseases at Apollo Hospital, Hyderabad. Sunitha, over to you.
Thank you, Dr. Gafoor, and welcome to this session on antimicrobial resistance. We are going to have an array of speakers and an array of topics. It's going to be a fireside chat, which means a lot of different topics that are going to be going on rapidly. And I would request Dr. Surabhi Madan to moderate this session. Dr. Surabhi is an infectious disease consultant at Marengo Sims Hospital in Ahmedabad, Gujarat, and runs the fellowship in ID program as well since 2021. And I request Dr. Surabhi to introduce the speakers and start the program.
Thank you, Dr. Sunitha. I'm Dr. Surabhi. Welcome you all to today's program. So without wasting time, let us start with the session. Our first speaker is Dr. Mohammad Niaz, who will be speaking on the games of bones, a superbug prosthetic joint infection. Dr. Niaz is an associate consultant in infectious diseases at KIMS Health Center, Thiruvananthapuram. He was selected as an emerging leader in international infectious diseases by ISID in 2022. Welcome, Dr. Niaz. Can we have your talk, please? Thank you.
Yes, ma'am. I hope my video is on and my sound is clear.
Yes, you are clear.
Yes. Thank you. So thank you for the introduction. Good afternoon, all. I'm an infectious diseases physician. In short, other doctors call us ID doctors or simply ID. So I can treat all kind of infections, but people don't call ID doctors to treat usual kind of fever that you see. So other doctors call ID when their options run out. So in a way, we ID doctors are no option doctors. So it's a challenge that we ID doctors like. Of course, that's why we have chosen this exciting specialty of medicine. But many times we solve these puzzles, these challenges, but there are times in which we also feel helpless. So this is a story of one such case where despite using whatever I've learned in infectious diseases, I stood helpless before a patient and watched death slowly taking my way. So this was 6 months back when I saw this patient, when I got a consultation from our orthopedics department. So this patient was a chef and he had an excellent quality of life, except that he had severe pain in the right hip. So the patient was diagnosed to have a condition called as osteoarthritis of the hip. And the doctor said that surgery is the only option for severe osteoarthritis. So he had undergone this procedure, which was called as total hip replacement from another hospital. And his joint was replaced with a prosthetic joint. So that is what a joint replacement surgery is. Everything went fine for a month, after which he noticed some fluid leaking from the surgery site. So he was alarmed, of course. So he went to the surgeon, who found that the joint was infected. So he tried something called as a joint wash and gave him some intravenous antibiotics as well. But the discharge from the joint won't subside. This was when he consulted our own orthopedic surgeon. So our orthopedic surgeon made a diagnosis of what is called as a prosthetic joint infection. It means that this prosthetic joint that is placed inside this person's hip is got infected. And that is a time when he had sent an infectious diseases consultant, and that is how ID comes to the scene. So this person was a pleasant gentleman in his 60s, quite jovial, but obviously distressed about his hip. Bone and joint infections are nightmares for orthopedic surgeons as well as infectious diseases physicians. Prosthetic joints are especially difficult to treat. They need further surgeries and prolonged course of intravenous antibiotics. Whenever I see a case of bone and joint infection, I remember my own professor, Dr. Cherian, who once told, "You may spit into the abdomen, but you should not even breathe into the bone and joints." Orthopedic surgeries have to be sterile. If not, life is going to be hell for the surgeon, to the patient, as well as the ID doctor who will have to treat it later. So this was a severe infection. The only option was to do an operation called as a two-stage exchange. Here, the surgeon will remove the infected joint processes, and with the help of ID, they will give a prolonged course of intravenous antibiotics, at least for 6 weeks. Then you wait for 2 weeks to see whether the infection has really settled, and then the orthopedic surgeon goes in again and puts in another joint. So this was what we had planned for him. So the first surgery went well. The orthopedic surgeon took away the diseased processes and the surrounding tissue, and he sent for culture. And when the culture results came, he called ID for the antibiotics. I was shocked to see the bacteria that had grown in culture. There were 3 organisms, not 1, not 2, 3. So first was a carbapenem-resistant E. coli. Second was carbapenem-resistant Klebsiella pneumonia. The third one was vancomycin-resistant Enterococcus faecium. I felt dizzy. Treating one of these organisms itself is a nightmare, and I had 3 to treat. And for those who don't know about what a carbapenem-resistant organism is, now carbapenems are like one of our high-end antibiotics, something like last resort or just before that. And once the bacteria are resistant to these drugs, carbapenems, then the options that we have, or the drugs that are left to treat, are limited and toxic, associated with a lot of side effects. But then you cannot just watch, you have to treat. So we have to make combinations of regimen. Our microbiologists did certain tests, and they told that a particular combination called as ceftazidime avibactam with another drug, aztreonam, along with the third drug, linezolid. So we started him on these 3 drugs. We had 3 organisms to treat, all of them extremely drug resistant. So these intravenous antibiotics has to be given through a special intravenous catheter called as PICC line, because the antibiotic has to go for 6 weeks or so. So we gave it for 6 weeks, and still there was an oral option that was available, which is called as cotrimoxazole. We shifted cotrimoxazole for 2 weeks as well. Initially, there was no discharge. His discharge subsided. His markers of infection came down, and we stopped antibiotics, and we were planning for the next operation after 2 weeks. But then the discharge started again. This time, the bacteria had changed. The organisms were the same, E. coli and Klebsiella, but the old combination of ceftazidime avibactam and aztreonam will not work here. So we went to the microbiologist again, and they tested for lots of antibiotics. And finally, we gave him a combination of antibiotics called ciprofloxacin and cotrimoxazole. These are older antibiotics. Fortunately, this time the organism was sensitive. Things went okay for a while, but then again discharge came back. We cultured again. There came another E. coli. Well, this time resistant to whatever we were giving. So then we had to add another drug called as tigecycline. This was quite a difficult drug, or a nasty drug, which causes severe gastritis and vomiting. Our patient could not tolerate it. Finally, we had to choose a regimen called as an intravenous fosfomycin and gentamicin, and we were continuing the other drugs also. Are these the best drugs to treat a prosthetic joint infection? Absolutely not. These are toxic drugs, and nobody is quite sure how well these drugs will act and how the outcome is going to be. But what options we had? None. And then we had to treat it with whatever options, whatever drugs we have. We treated with these combination also, but the joint still continued to throw multiple organisms. The same organism, E. coli and Klebsiella, have a different susceptibility. We treat one another organisms with different susceptibility observed. We used all possible combination, adding new drugs, changing the combination. We tried this for 6 months. 6 months, this patient was on intravenous antibiotic. Nobody can be hospitalized for this long. The financial constraints are too high. And so we treated him on an outpatient basis. He would receive his drug from his house. His son, by this time, has learned how to put an intravenous drug through the PICC line. I couldn't say no to him. I knew the financial burden of getting a nurse at home. The patient would also develop all the complications of this drug. Most of them I would manage with the help of a small clinic there. So he had hyponatremia, hypokalemia, all those complications that are associated with antibiotics, which were managed through telephone and with the help of a local clinic. And a month ago, he was admitted again. This time he was too sick to be managed at the local hospital. Much has changed in this gentleman over the 6 months period. He was just a shadow of his older self. And he was cachetic. He had lost most of the flesh and his hairs had become sparse. This time his BP was down and we knew something was going on, and this is something like we suspected a sepsis. There is some kind of an infection in the blood aspect. And we sent up what is called as a blood culture to see what organisms was growing in the blood. And in the blood, there was a growth of a yeast. A yeast is a fungi, so yeast had grown in the blood. And we knew that the yeast could come from nowhere except the PICC line. Okay, the PICC line is the line through which we will be giving antibiotics. We had to remove the PICC line and started him on antifungal medicine, what we call as caspofungin. He wouldn't unfortunately improve. Slowly his hypertension worsened and he succumbed to his illness. A day later, the yeast was identified as Candida guillermondi. This is a yeast and a fungus, which was resistant to the caspofungin that I was giving him. So in short, a hospital-acquired infection made his life miserable. Another one took his life. This is not an isolated story. All the speakers who come after me will have similar stories to tell. AMR is no longer an issue on the paper. It is something that is going to affect us all. It's time to be aware. It's time to act. Thank you. Thank you, sir. Thank you, the AMR Trust and Dr. Kapoor, for giving this opportunity. Thank you.
Thank you, Dr. Niyaz. I think this was a perfect start, though very scary and horrifying, especially for the patients who go through it and for the doctors who treat these infections. This was a perfect start to our first session, which is rightly called No Treatment Options. I think with this, we move to our next speaker. I would request all the speakers to stick to a time limit of maximum 8 minutes because we have 5 more speakers in this 1 hour session. And if time permits, we will have quick question answer session at the end of this whole session. The next speaker is Dr. Soumya Sridharan, who is a consultant infectious diseases at Apollo Hospitals, Chennai and Toliarpet. She will be speaking on the Proteus and the Pandora's box. Welcome, Dr. Soumya. Over to you.
Thank you, ma'am. So good afternoon. At the outset, I would like to thank Dr. Ghafoor and the AMR Trust for giving me the opportunity. This is a small part that I am playing from my side to combat the rising antimicrobial resistance. I'm just going to echo Dr. Niyaz's opinion that being an ID doctor, we are always the last resort doctors or the no option doctors. We just are not called in to solve easy puzzles. So our life is a misery every day. But I think we can become more tactful if we combat AMR cleverly. So I'm just going to start off with one patient, not so easy kind of a bug, but in a very easy scenario that we always come to see in our day-to-day practice. So this was a middle-aged lady around 38. So she was quite young. And she came in, she was apparently healthy and from the community. She didn't have any other problems. All started off with some dysuria, difficulty in passing urine, some burning sensation. And this was around 10 to 15 days ago before she came here. So at that time, she was very hesitant to go to a doctor even. So she just spoke to her neighbors and took some medicine which the neighbor had used for the same problem which the doctor had given. So she didn't even know the name of the medicine that she used. So after she started using it, she said she started feeling better. And so she just self-medicated for the next 3 to 4 days. But again, she started to have all these burning sensations and some feverish feeling. And only then did she open up to her family, and her husband took her to the nearby clinic. The GP, the general practitioner there, had switched over to another antibiotic, likely ciprofloxacin, and she was given 250 milligrams of ciprofloxacin for 5 days. And he had not done any other investigations and had reassured her that she will feel better. And she started the medicines and she started feeling slightly better. After 3-4 days, she felt that the need for antibiotic was not there because already she had taken some 10 days of medicines now, and she stopped the medicines. Nor did she go back and tell the GP how she felt. And about 3 or 4 days after stopping the medicines, she again started having same problems, and her husband brought her to the emergency in our hospital. And on admission, she was quite stable. So we sent off the routine battery of investigations, blood cultures, urine cultures, and are ordered for scans, etc. And started on empiric beta-lactam, beta-lactamase. This is one of the drugs that we generally start patients on based on our bug profile here. So after she was started on this medicine, in a few hours, she worsened. Her BP dropped and she became more drowsy. She did not respond to the medicines that we were giving. And so we shifted her to the ICU. In the ICU, again, she was deteriorating. So we escalated, we increased the antibiotics, we switched to a different class because it was just 3 to 4 hours into admission. We hadn't got the culture reports. And the CT scan that was done showed some collection in her kidneys. So she had some pus collection in the kidneys, which we call pyelonephritis, and with a renal abscess. So she had to be taken for an emergency surgery. Her BP was dropping further despite medicines to control her BP and keep it on hold. With all these problems, she was shifted to the operation theatre. She underwent the surgery and we took out the pus and sent it to cultures. Waiting for this, we again escalated antibiotics to colistin, but again, she continued to deteriorate in front of our eyes. We didn't know what problem or where the problem was. Then later on, despite all the resuscitative measures, all the measures in the ICU, she passed away just in front of her eyes in a matter of few hours. And the next day, the blood had grown a gram-negative bacteria, basically a bacteria. 2 days later, after her death, we got to know it was a drug-resistant bacteria. All the bacteria, all the drugs available were resistant, including including the highest antibiotic, carbapenem, that is meropenem for this agent. And unfortunately, as she was in a small town, it took some time for her to come to help and seek medical help at all. So in her case, I do not know what went wrong or where we went wrong. Was it the patient's fault that she used some medicines used by the neighbors? Was it her fault that she stopped the antibiotics before? Was it the GP's fault for giving her some more antibiotics, underdosing her and not asking for a culture, or using a drug at a reduced dose? Was it the disease's fault itself? But this was a seemingly normal infection that all of us could get day to day in our life, a simple urinary tract infection. But that took away the life of a 38-year-old just because of a renal abscess with a wrong empiric antibiotic choice with all pan-resistant bug. So we do not have the answer for all of this, and it's high time that we ponder about more questions about how to tackle antimicrobial resistance. Maybe we should be more prudent to get more tests, order cultures before we offhandedly start antibiotics, because we all have a responsibility towards the society. Thank you, ma'am, for offering me this opportunity. Over to Dr. Surabhi.
Thank you, Dr. Soumya. Yeah, so I think we have started understanding what kind of bugs are we seeing in our day-to-day practice, and we have 4 more speakers who will be emphasizing on the same fact. So our next speaker is Dr. Rahul Garg, who will be speaking on the new avatar malaria. Dr. Rahul is PDCC infectious diseases from AIMS Bhopal and is presently working at AIMS Raipur. Welcome, Dr. Rahul. Over to you.
Thank you, ma'am. Can you hear me, ma'am?
Yes, you are audible.
Okay. First of all, thank you to the AMR Declaration Trust for giving me the opportunity to share the story of unfortunate but not the rare one, and thus making it fit for as a no option treatment, where at the the treatment was not given at the right time, we have seen many such patients have been succumbed in our own eyes. So this is a story of a district in Chhattisgarh known as a Bastar district. I hope all of you have heard of Bastar district. It is surrounded by impenetrable forest and hills in what was known as a Naxalite territory a few years back. And there is a tribal village known as Buddhi Maha, which unfortunately doesn't got the government attention till now. And this village don't have any pakka road, electricity, and the mobile coverage is also not possible for this village. And the unfortunate part is the nearest sub-center for this village is around 10 kilometers away. That is there, the Indian primary healthcare system, which we call as a sub-center. And most of the villagers belong to these tribes practice local farming, clearing the forest lands and growing the paddy and the local crops there. So I'm taking you to this village for a reason. So this is a story of October 2022, recently at the time of Diwali, where the festive atmosphere was there in this village in the tribal Bastar area. A 14-year-old resident boy was brought up to a nearby sub-center, which was around 10 kilometers away from the village, with a history of fever with chills and rigor. The fever was around 101 when this boy presented to the sub-center. The fever was from last 4 days, followed by a dull abdominal pain. He was taking some herbal medications from a local Baba for the last 3 days for decreasing this fever and getting healthy. So this boy was seen by a local community health worker in the sub-center who was posted in a sub-center there. And a rapid diagnostic test in the form of a kit was done to rule out malaria at that point of time. And that rapid diagnostic test came negative at that point of time for this boy as a reason for malaria. So he was prescribed tablets Cefixime and some supportive treatment and was sent to home to take these medications. After the fever persisted for next 2 to 3 days, and he again came to the sub-center with the same symptoms, but now aggregated with dilating headache, vomiting, decreased urinary flow, and altered consciousness gradually in 2 to 3 days. Fortunately, at that time, the same healthcare worker, the community healthcare worker was there who has seen previously this patient. And they referred to us directly to the tertiary care hospital in All India Institute of Medical Sciences, Raipur. This case was sent. And when the patient presented to us, the patient was drowsy but arousable, and he was having a toxic look with mild jaundice was there, and his pulses was very feeble. On asking to the patient's family, they told that he is having the similar type of fever 6 months back too. At that time, his BP was very low, around 100 to 60 mmHg, and temperature at that time noticed was 103 Fahrenheit. He was anemic with low platelet count too at that point of time when the investigations were done in our hospital. On examinations at that same point of time, his spleen was palpable up to 2 centimeters below the left costal margin, and he was having increased liver enzymes too at that point of time. So that time only the smear microscopy was taken to rule out malaria, and again various tests for dengue and leptospirosis was done to rule out these infections which are common in that tribe or that area. And the smear microscopy and again the rapid diagnostic test was performed. Both came positive for Plasmodium falciparum, which is a parasite that came positive, which in both the smear and the rapid kit. That point of time only, we have started with IV artesunate, which is the treatment for cerebral malaria per se. But unfortunately, the patient succumbed on day 2 of the therapy when the artesunate was going on. And this story is thus a very unfortunate, but not a rare one to fit at this point of time at this session. So the paddy fields, the thick forest, and the slow-moving streams encourages the breeding of the Anopheles mosquitoes, which are prevalent in Chhattisgarh, Odisha, Jharkhand, and other northeastern states of India, and thus making the falciparum malaria widespread in these certain states. With the poorest access to the quality healthcare facilities, most patients are treated by the local quacks, and the prevalence of submicroscopic or the low density infections are again a concern which are prevalent in these areas. And the government and we all have looked into it many times. Such patients have came to us in the emergency or in the OPD. By that time, we can't do anything for these patients. Thank you.
Thank you, Dr. Rahul, for sharing this story. Yeah, I think we all felt a little sad after hearing to this story. And the peripheral centers are in real need of attention from the government. We all agree to that. Let us move to our next speaker. She is Dr. Subhashri Samantri, and she's going to speak on the TB diaries. She's pursuing her DM in infectious diseases at AIIMS Jodhpur at present, and she has been a gold medalist during her post-graduation. Welcome, Dr. Subhashri. Over to you.
Thank you, ma'am. A very good afternoon to one and all. So after listening to these interesting cases of prosthetic joint infections, UTI, and malaria, let's move forward to a disease that has been endemic in India since 19th century. So here I bring forth a case of a 26-year-old female patient who was a student who was at the verge of completion of a master's degree, and she wanted to finish her exams first, like who are coming in the next 2 to 3 months. But then one morning, she started having a disturbing headache and vomiting. She thought it could be because of the exam stress and the sleepless nights for exam preparations she has been spending for last few days. But over the next few days, she also started having mild fever which was more often in the evening time. They would relieve on its own with lots of sweating. She kept it hidden from her family because she did not want to add any more trouble to her already troubled family. After all, her father was a grocery shop owner and had just completed his 1-year treatment course of drug-resistant pulmonary TB infection just the last month. It was a tough 1 year for him as well as the entire family because he had to face lots of financial and emotional difficulties dealing with lots of side effects of the drugs like vomiting, tingling in legs, and psychological disturbances, and also multiple visits to the doctors to manage them. But then again, she started having fever and headache almost every day. All that she wanted is to finish her exams well. However, she secretly consulted a local doctor who gave her some analgesics and some antibiotics. As roughly she could remember, it was levofloxacin for 7 days. With that, she got some symptomatic relief. She would secretly get these over-the-counter drugs as well as levofloxacin time to time to get some temporary relief from her symptoms. But gradually, over the next month, she lost her appetite and also lost weight drastically. This could not go unnoticed by her family. They thought that this could be due to the exam stress, but again, this much stress is unwanted. When her mother spoke to her, she told her about the health issue she had been having for the past 1 month. Then she agreed to go to the doctor for the consultation as the symptoms had started worsening and was disturbing her studies already. But the same night, she had multiple episodes of vomiting along with fever and severe headache, for which she had to be rushed to the hospital emergency. So she was stabilized in the emergency and next morning shifted to the ward. So fortunately, she was hospitalized in our hospital itself. So we examined her thoroughly and everything seemed normal except some amount of tightness of the neck. So on routine blood investigations, what we found is there was mildly elevated leukocyte count and little raised inflammatory markers. However, the next morning, she again had a high-grade fever and could not lift the left side of her body. We convinced her family and performed the lumbar puncture. So this is a procedure that is performed by inserting a specific type of needle in the spinal cord and getting the clear fluid that's called a CSF, which flows in and around the brain and the spinal cord. The next day, we got the CSF reports. And because of the strong contact history with the TB case, we also sent the sample for the Gene Expert Ultra. So what is this Gene Expert Ultra? It's a test that can detect both tuberculosis bacteria and the preliminary drug resistant status within 2 hours, especially in the samples who are supposed to have low bacterial load. So that is Gene Expert Ultra. So to confirm our suspicion, we got the reports of Expert Ultra as well as the CSF findings, which was positive for tuberculosis, but fortunately, it was a sensitive strain. So we counseled the family that this was just the preliminary investigation and we have to wait for the other higher tests like drug susceptibility testing for starting appropriate treatment for her. But before that, she had to be started on the basic drugs for the susceptible TB. So we started her on the anti-tubercular treatment that is provided by government free of cost. So we provided the drug that is famously known as HRZD from the nearest DOT center that was attached to a hospital. Along with that, she developed the brain infection. That's why she had to be given mild dose of steroid as indicated. So on the day 3 of treatment, she started having itching and rashes all over her body. So this was suspected to be some allergic reaction because of the ATT. So that was immediately stopped. Then she was given individual drugs one by one, and we found that the one of the ATT, known as pyrazinamide, so that was the culprit. So from that time, her regimen was modified to the HRE, which was still available at the DOT center free of cost. But by day 7, she started having sudden confusion and speech difficulties, and you could not identify her family members as well. By then, the drug susceptibility reports by line probe assay, that's a commonly used test at the NTEP designated centers. So the reports were available with us, and we found that she was a case of drug-resistant TB, being resistant to the other common drugs like isoniazid, ethionamide, and even the higher drug, that is levofloxacin. So we wanted to put her on a combination of second-line drugs that would effectively treat the brain tuberculosis, but her family had to purchase these drugs for treatment because they were not available free of cost by the government. So however, we made a few drugs available free of cost. We designated a regimen for her consisting of few drugs like linezolid, cycloserine. Those will have some penetration into the brain. We counseled the family that there was limited options available for treatment of brain TB, and also in her case, we are expecting slow response because of the delayed reporting to hospital and extensive brain involvement that was confirmed on the imaging. She remained hospitalized with us for 48 days, but it was a great psychological and financial burden for her family. And finally, they decided to discharge her from the hospital against medical advice, leaving us with no options to treat her. So my message for the public will be, don't neglect your symptoms if they are persistent beyond 5 or 7 days. And also, the over-the-counter drugs are to be strongly discouraged. And for the other physicians, please don't use drugs like levofloxacin casually, even though there are very good oral drugs available for multiple infections like urinary infections, respiratory infections. Still, in our case, it might have provided some temporary symptomatic relief, but it suppressed the tuberculosis symptoms. And again, it led to the resistance to fluoroquinolone, so which limited her treatment options for future. Being updated about the newer investigations like Gene Expert and Expert Ultra for rapid diagnosis of common conditions like TB is very, very essential. As Government of India updates its guidelines like NACO and NTP time to time, we have to be updated on this. So with that, I'd like to conclude my talk, and I thank AMR Declaration Trust for the opportunity.
Thank you, Dr. Subhashri, for bringing to light such a common but yet challenging disease many a times, especially when we have drug-resistant tuberculosis. And this was a doctor, and she took a lot of time to come to the hospital setup itself. Yeah. So thank you for giving good messages through this case. Now I invite our next speaker, who is Dr. P.S. Sharik. He's a consultant infectious diseases in SUT group of hospitals, Trivandrum, and he will be speaking on super pseudomonas and a broken foot. Over to you, Dr. Sharif.
Thank you, Dr. Surabhi, and thank you, AMR Trust, for giving this opportunity. So today, all this time, we were seeing how life is getting affected. I mean, like mortality or how many people die. I have a different story. I had a patient who was literally drawn to the streets just because of this issue. So that was a huge emotional and financial problem which we faced because of this one. This is a story of a poor mason and from South Tamil Nadu. Basically, they have more of a masons over there. He was a diabetic, and what happened was that he just goes for that, and he has 2 kids. So his ambition was to make his kids into give more education and all those things. Once they find it, and he happened to be a diabetic, he has sugar. So he goes to the doctor, takes some medicines, and goes in that. One day he sustained an injury. His stone fell on his foot, and then he had an injury on his foot. And from there, the story began. Now, he went to a local doctor, got a dressing done, got some antibiotics, came back. But then what happened was that he took the medicine, but it was not improving. So he went to the local doctor once again, and he put him on a new antibiotic, and the dressing was continued. It started improving, but then again it comes back. So this story was continuing over and over, and the doctor over there was prescribing many medicines. I mean, like he was taking type of antibiotic. Initially he was given amoxicillin, clavulanic acid, then he was given linezolid, then he was given clindamycin. So there were almost, it went for almost 4 or 5 cycles of antibiotics and dressing. But then one fine day, doctor said that this wound is not improving. We will have to admit it. And they admitted him. They took some cultures, and based on that, they have started on IV antibiotic, hoping that this patient will improve. But every time this patient starts showing some improvement after 4 or 5 days, they stop that and change to some other thing, and the patient will go. But this again, 2-3 times they did that. By that time, it was almost 1.5 to 2 months. But suddenly, the son decided that this is not going to be on the right way. We will go to a next bigger hospital. And they took his father to the nearby hospital. By that time, the wound was very bad. So he came in such a fashion where he was exposed to multiple antibiotics many a times with small intervals, 4 or 5 days kind of stuff. But when he presented to our hospital, his leg was into more of, there was severe infection in, and he went in to meet a surgeon. So the surgeon said that this is not doing fine. I think we will have to admit him, and probably we will have to do some cutting of this area for optimal healing. Remember that he is a mason, so his bread and butter is work with it's a manual laborer. So the son who was there said, okay, we will admit. And then what happened was that he took a CT scan to see what is the extent of the infection in. So by this 1.5 months time, that wound has gone deeper in to the bone, where it has produced a lot of infection in the bone, as well as a lot of pus collection was there in the bone. Now the surgeon said we will go in for a open surgery to remove all the pus and tissue over there. They had to agree, so they agreed, and the surgeon took him to the theater, did a drainage of all those things. He removed all the pus and all the debris and all the necrotic muscles and tissues over there. And he called me. By that time, he called me and asked me what antibiotic to give. So I thought that this is a very tough thing. He has received a lot of antibiotic. We'll start on the highest end antibiotic. So we started him on something called colistin plus TG, because he is already exposed with multiple things. We started on high-end antibiotics. We started it. And one day he came back to the ward, so it's okay. But the second day by evening, suddenly the nurses in the ward noted that this patient was started talking in an irrelevant way, in a very irrelevant way, and started breathing very deeply. Now they examined him and found that his BP was coming down. Oh, this was a trouble. So the doctor also rushed in. I was not there. The surgeon rushed in and shifted him to the ICU, where he was diagnosed to have something called a septic shock. Septic shock means his BP has come down because of the infection, and we decided to start on medicines for his BP and all those things. So by that time, what happened was that next day when we went in, so debridement, everything was done, but the patient was not improving. So next day when we went in, the surgeon was showing me a report, and the patient, the leg was by that time was not improving. that report actually showed a bacteria called Pseudomonas. And on the right side, that is where we say which antibiotic is sensitive, which antibiotic is resistant. Everything was resistant. So I was shocked. All those things was resistant. Even the highest antibiotic was resistant. I called the microbiology people and asked, what is this happening? Is there anything else we can do? Because this guy is in real trouble. We have no other way. So he's going into shock mode. So end of it, the microbiologist told that absolutely no way, Dr. Sharik, there's nothing in. So then we had to decide to go for a chopping out surgery. We call it as an amputation. There is no other way. So we decided we'll go with an amputation. But the issue was that it was very difficult to convince the bystander. I mean, the son was an engineering student. He was a guy. So he said that, is there any way we can find new antibiotics so that we need his leg back? Because that is his bread and butter. That is the whole issue of the family. So we said, whatever be, it's not the amount or the expense which is the issue here. It is the resistance issue. We will not be able to save his life with medicines. We'll have to chop his leg. We had no other way. That was one of the most difficult scenario in our life. So we decided to chop it out. We chopped his leg out. We had no other way and started with him some more 1 or 2 antibiotics so that his thumb doesn't get infected. So what happened is, end of the day, we saved his life. But you know what? Emotionally and financially, those family suffered a lot even after that. He couldn't go for his job, and then he had to put him on artificial limb. So what we see is just the tip of the iceberg. Diabetic foot infections is very common and amputations are also very common. But what we see, the real issue with the superbugs or the so-called no option bugs, is what we are seeing is just the tip of the iceberg. There are a lot of other things. So it has huge issues as far as the life is concerned, as far as the financial part, as far as the emotional part as well. This is one case where the financial part or the whole family got shattered because of one superbug. Thank you, Dr. Surabhi.
Thank you, Dr. Sharik. Yeah, I'm 100% sure that, what we come to know is just tip of the iceberg. We just treat the disease, but at the back, so much happens with the family when these super bugs or so-called resistant bugs are isolated. The emotional trauma, the financial burden, and ultimately very poor outcomes in many of the cases. That is something which we may not be able to, come across in all the patients all the time. Yeah. So you are true. Absolutely. Now we move to the last speaker of this session, Dr. Akshata. She will be speaking on bad affairs of your heart. Dr. Akshata is a senior resident at AIIMS Jodhpur, DM Infectious Diseases. She's pursuing it, and she's actively involved in antimicrobial stewardship since 2018 and formulation of institutional antimicrobial policy. Welcome, Dr. Akshata.
Surabhi, let me interrupt here. Akshata, 1 second. Anyone, any questions from the audience, please put it in the chat box. And over to you, Akshata.
Yeah, thank you, ma'am. And I thank AMR Trust for taking this initiative. So this is actually the need of the hour. As we all know, antimicrobial resistance is a much bigger pandemic, which we fail to address when compared to COVID. And there are not many common people who know or talk about it. So like it is said, a patient teaches you more than what you'll learn from the books. So we shall directly jump into the story of the patient whom I'll remember forever. So we had a 50-year-old man who was leading a happy life with his family, his wife and his 3 daughters. By occupation, he was a tailor and he was earning sufficient enough to sustain his family. He had actually recovered from a heart attack last year, and at that time he was actually advised to undergo angioplasty. Due to the financial constraints, he couldn't undergo. Now, and he had another episode in this December 2021 when he had to undergo the angioplasty for the coronary artery disease, which is nothing but a heart blockage. All things were fine, but he started having some fever and chest pain in January, for which he took some over-the-counter medication and it would subside. When even after 2 weeks, it didn't subside, he had to go to a hospital and he was said to have some chest infection, pneumonia, and he was treated with some antibiotics, IV antibiotics for some 5 to 7 days. So at the end of in the Feb, he developed stroke, and at that time he even had fever, and some blood investigation showed that there was some growth of bacteria, so which was treated for 14 days. Next 2 weeks went uneventful. However, his symptoms reappeared. He had fever, chest pain. He developed difficulty in breathing. And at this time, his wife had to take him to the emergency. There, he was diagnosed to have pulmonary edema. So, in common words, it's a condition where the lungs are drowned in its own secretion. So, he had to be admitted and ventilated in the ICU. So another 2 weeks in the hospital with multiple antibiotics, he was treated. And the family were hoping that this is the last time he would require hospitalization. But fate had its own way. So next month, he had this similar complaints of fever, chest pain, and this fever had shaking, chills, and body weakness. So this is when he came to us for the first time here at AIMS Jodhpur. At that time, we saw that he had the swelling of his legs. There was some abnormal sounds in his heart, and the blood test showed that he was having anemia and a very high amount of WBCs, which is an indicator of some infection. And also the other blood tests like ESR, CRP was very high. So the blood cultures were drawn and he was started on the antibiotics. And it was when it was reported that it was a multi-drug Pseudomonas aeruginosa. So now is where the ID specialists get involved. This is when I got a call for this patient. That is when there are no options to treat the patient. So now when I evaluated the patient had the symptoms of multiple fever episodes, chest pain, and bacteria was growing persistently in his blood, and he has history of multiple strokes with fever. So I suspected that it could be some infection which is in the heart. So that is called as infective endocarditis. So as we all know, it is the heart which pumps the blood to all the parts of the body. So if there is a vegetation or the infective clot in the heart, so whenever heart pumps, there is infection which is spread, and at this time it is when the patient will have fever. And if such infected clot gets lost in the brain, that is when the patient will have stroke. So that is when I suspected and subjected the patient to certain investigation like echocardiogram and PET scan to confirm the diagnosis. And obviously, and the diagnosis was confirmed that this was a case of infective endocarditis, and it was due to the infected stent which was placed in December 2021. So now the next thing is how to treat this patient. So the patient had Pseudomonas aeruginosa, which was resistant to all the common antibiotics which we use, and this could have been due to the multiple antibiotics he had got before, and including the over-the-counter medication. So we had to put him on a very high-level antibiotic, and which is difficult to get, and it is very costly. That is the ceftazidime, avibactam, and aztreonam. And because there was an infection in the stent, the infection source had to be removed, and without which the patient will not do well. So we had to undergo another surgery, the bypass surgery. So by this time, the family had already exhausted most of its money, but we had to convince, and the patient had underwent the bypass surgery. So we were thinking all well, but when the blood, we subjected further blood tests, and the blood was still growing this drug-resistant Pseudomonas, and he was developing multiple fever spikes. Despite all this surgery and the antibiotic regimen, the patient's condition deteriorated and he eventually succumbed to the sepsis caused by this pan-drug resistant Pseudomonas. So because there was no option. So this tragic case highlights the potential dangers of multiple courses of antibiotic inappropriate dose, and also the importance of early identification and aggressive management of infective endocarditis. Thank you.
Thank you, Dr. Akshata, for bringing upon this case, because I think this was a little unique case in the sense that it was a purely hospital-acquired infection and maybe related to a poor infection control. So we are done with all the speakers and we still have 10 odd minutes to finish this session. Now I would request Dr. Sunita Nareddy to, just ask our speakers, eminent speakers, a few questions, and we can have some discussion on the topics which they have presented. Over to you, Dr. Sunita.
Thank you, Surabhi. So I would like to ask Dr. Rahul, you presented a case regarding malaria. And we know that malaria is as much as a public health problem as much as it is a medical problem. And especially in certain pockets of the country. So what is the government's attention towards the villages in Chhattisgarh where you have a lot of this problem particularly?
Thank you, ma'am, for asking this question particularly. So Chhattisgarh government starting from 2012 has been under the phase 4, phase 5, phase 6, and now the phase 7 program for the malaria elimination. Has done a lot of work, particularly from the help of community health workers, which are there. So they are basically not a very well-trained community health workers. They are around 10th pass, metric pass workers who have been trained basically on the surveillance, on the treatment and how to diagnose malaria cases clinically. They have been trained. And if you see the API index for malaria, annual parasitic index, which from 2012 to 2021, starting from the last 18 districts, the API index has decreased from 18 to 2.9. That is there, the latest data which is there, government data which is there. But again, there are 3 or 4 districts in Chhattisgarh which are hyper-endemic to the malaria belt that is there. And the API index in that 2 or 3 districts that is there is around 8.4 or 8.5 that is there. So government is doing a lot, particularly in these districts. They have started Malaria Mukt Bastar program, Malaria Mukt Dantewada program that is there. They are doing their work. But again, per se from the ID part and the clinician part, the availability of the rapid kits, the smear microscopy, and the treatment which has to be given, the artesunate based treatment that has to be given, that is particularly lacking a lot in these particular areas. It is there.
Thank you, Dr. Rahul. And question to Dr. Niyas. Dr. Niyas, what are the reasons? You presented a case on drug-resistant infection. So what are the reasons for drug resistance to develop, and how do you prevent drug resistance from developing?
Yeah, problem with some the camera.
We can hear you, Dr. Niyas. Just go ahead.
Yes. Okay. So again, drug resistance is something that we have to understand in terms of the evolution. Now, whenever an organism, a group of bacteria are exposed to antibiotics, these organisms which are intrinsically resistant to a particular antibiotic can get selected out. That is a particular reason by which we say that overuse of or injudicious use of antibiotics, either it be in the clinical practice or in poultry or agriculture, which can select out resistant organisms, which can cause the emergence of antimicrobial resistance. So So these are the factors that we have to be especially aware of, that is injudicious use of antibiotics, which we have to tackle by the antibiotic stewardship practices. But that is not alone. That is only a tip of the iceberg. There is a lot of antibiotics that is being misused in poultry and as well as agriculture. So all the environmental bacteria being exposed to these antibiotics, and as a result, there will be a selection pressure as such. So the resistant organisms being selected out, and which can cause infection in human beings.
Dr. Sunita, please unmute yourself.
Dr. Subhashri, I have a question for you, Doctor. You presented a case on a young person with tuberculosis and who also had a family history of someone who has TB. Now, when anybody is diagnosed with TB, the first thing that we say is, how come I got it? There's nobody in my family had it. Here in this case, somebody had it. So who are the people likely to develop TB? And what are the, here we have a major issues about financial constraints. Today, the government actually has come up with a program whereby everybody, irrespective of the financial status, are taken care of. What are the things that the government is doing in terms of helping people with tuberculosis, especially with the 2035 coming up, and we have to meet certain guidelines for the WHO?
Yes, ma'am. Yes, ma'am. In this case, actually, the patient had a strong contact history with the family itself, with the father. But in most of the cases, the people give us a history that there is no exposure at all to tuberculosis case. But suppose, especially in the endemic places, like in the crowded areas, like suppose like if person is a stone worker or living in the poorer conditions. Okay, so in that case, actually, where the crowding is more, that time we cannot prevent it from getting it, and we don't know who is the source. And there are many cases, especially in the post-COVID era. So people will have some symptoms like cough and fever, and which could be because of like tuberculosis or any other infection, but they attribute it to some viral infection or some mild infection, and they hesitate to go to the doctor. They hesitate to report the symptoms. And then I'm coming to the government. The facilities that have been developed actually for increasing the awareness and also for increasing the diagnosis and management of TB cases. So we have NTP designated centers like in every state, almost in every district, where the gene expert, the microscopy, the CBNAT and the line probe, they are available free of cost. So there are few designated centers in every state. So like even in the peripheral centers where these facilities are not there, so they can send the samples still to the referral centers. And also, ma'am, regarding the treatment, there are even the like bedaquiline based regimen, the oral short-term regimen, the long-term regimens, they are also available at the DOT centers free of cost, even for the drug-resistant TB. And the government is also working on the newer regimens like BPAL regimen for the other XDR TB cases. So we have to, being doctors, being the primary people who come in contact with the TB cases, we have to be aware of these updates on the newer diagnosis and newer management for reducing or for managing the cases properly.
To add on a little bit more onto that, now if you have a patient even in the private sector who is getting who needs treatment for drug resistant TB or drug sensitive TB in some places, the patients can continue the treatment in the with your own clinician wherever he or she may be, and still get support through the government. There are programs available whereby you can send your own patients to the government to get the medications, or you can procure the medications. So I think we are almost out of time. Over to Dr. Ghafoor. Dr. Surabhi, you want to close the session?
So I think and I believe that it was a very fruitful session covering the bacteria, the parasites like malaria, as well as tuberculosis. I thank Dr. Sunita and all our speakers for presenting all the cases so nicely and so effectively. And I thank Dr. Ghafoor for having me in this program. With this, I would like to end this session and hand over to Dr. Abdul Ghafoor again. Thank you, sir.
Thank you, Dr. Surabhi and Dr. Sunita Reddy. Next, we will have our media session, and that will be moderated by Ms. Adwaita Kala. And Miss Advaita Kala, as you know, is a very famous Bollywood screenwriter. And I'm sure you watched the movies, Bollywood movies, such as Anjana Anjani and Kahani. And actually, Miss Advaita Kala was the scriptwriter for the screenwriter for these movies. She's also an accomplished media personality. She has a YouTube channel called Kahali and that has got around 50,000 followers. And she regularly interviews senior politicians and other important personalities in her weekly interview channel. And you can also watch her on national TV channels debating on important political and other important issues. And Miss Advaita Kala is also a novelist. She has written 2 novels. And Miss Advaita, it's an honor to our trust and the webinar to have you as the moderator of our media session of No Option webinar. Advaita, over to you.
Thank you so much, Dr. Ghafoor. And I just want to thank everybody for being here today and engaging in this very, very important discussion that impacts all of us. I, of course, bring the common person's view, and I do ask for your forgiveness prior to starting if some of my questions seem very, very simplistic, but I think it's important that you all are experts, but the people like us who pop these pills and follow this kind of self-treatment and self-medicating path get to really understand what we're dealing with here. And I'm delighted to be joined by a very, very expert panel on this subject, starting with Ms. Ramya Kannan. She is the Chief of Bureau for the Hindu. She is not able to be here today, so we have had her recorded message for all of us to view. I think Dr. Ghafoor will set that up once I'm done with introducing our panel. Then, of course, we have Ms. Viveka Roy Chaudhary, editor, Express Healthcare and Express Pharma. Viveka has done her BSc in microbiology and biochemistry, and now has moved to science journalism. I think that's such an interesting path, and I'd love to know more about that, of course, apart from our main topic of discussion. Thank you so much, Viveka, for joining us. And then we're joined with next generation, someone from the next generation who's probably going to be wiser and smarter than we have been when it comes to self-medicating, like we do so often in our country. Hina Parveen is, of course, a class 7 student, and she's also an author of the science fiction, The Mission and the Mangoes, a book that I've read, and I've also interacted with Hina in the past about her book and her very, very wise thoughts for someone her age. So I'm really delighted to have her perspective on here as well, because I think it's important to listen to the kids. Hina, although you're a very wise kid, I'm still going to call you a kid, but it's very important to listen to what they have to say and how they perceive this subject. So over to Dr. Ghafoor, and let's have the video now, and then we'll get back to our conversation. Thank you so much.
Mine, can we upload Ramya's video recording?
Hello, and thank you for inviting me to be a part of this important meeting on antimicrobial resistance. You might wonder what a journalist has to do here. I mean, it's a gathering of experts and even more experts, but then we have also, as journalists, as a community, especially health writers, have also had a role to play in the unraveling of this mystery, the resistant antimicrobial resistance, rather. So I just have a few points to make, and I'm happy to, I would have been really happy to be present at this online meeting, but unfortunately I had a prior commitment to travel that day. So I beg your indulgence to accept this as a recorded message. Like most of us, you know, like the world in general, had, you know, very little idea. We didn't even have an idea about antibiotics resistance, you know, for the longest while. I mean, as a journalist, I had come across drug resistance earlier, particularly with writing on TB and HIV, but not, AMR as we know it now. So most of us, sort of woke up to this with the publication of the NDM1 paper, and that paper was like a catalyst of sorts. That every major reaction has a catalyst and a milestone. So probably the NDM1 paper was a milestone for this, this entire AMR issue. And what it did was, sort of urged action, and it dragged the issue of AMR from inside ICUs and hospitals, by its feet, kicking and screaming into the public consciousness. So I'm sure all of you believe this too, but if you think back, it's a human assumption. It's a natural human assumption that people have, that drugs will help them, will save them, will cure them, will treat them. It will remove pain from them, and it will make them better. But this is the assumption that most of the world operates on. I mean, there is a significant anti-vax lobby now, but let's not go there yet. I'm talking about a significant rational population that believes in medicine as a sort of rescue in times of need. So this is a confidence that has naturalized itself into our consciousness. So our abiding faith, and though we don't really think about it too much or ponder about it or discuss it, our abiding faith belief is that we will be healed, and if needed, we will be saved by medicine. I mean, whatever it is, that system of medicine you believe in. But we have vested faith in medicine to cure us and save us, treat us, keep us happy and free of pain. Then imagine finding out one fine day through a paper that most people didn't understand and struggled to interpret, through a series of, through an alphanumeric series, that, we discover one fine day that when you're really, really sick, the most powerful antibiotics will do squat for you. Okay, this, and when you want it most, it will let you down. It will shake your faith you have in modern medicine or traditional medicine, whatever. And also the realization that you had nothing to do with that set of circumstances. You are, a tool, a plaything in this whole, march of events. You have no control over what works for you and what doesn't. And that was a very, very sobering reality. So if we were to look, at it from today's perspective, it's more conceivable now that this, this huge looming bugbear, huge looming sort of specter is out there in front of us, because we are still in the pandemic phase. So we may be moving out of it, but there are still swaths of the world that are still badly affected by COVID. We can still smell the threat to life as we knew it in the last 2.5 years with COVID, and most people at least. But then, at that point of time, it was inconceivable, maybe in 2013, 2012, it was inconceivable to imagine that pathogens were wily enough to survive the onslaught of man's best drugs, the best drugs that were evolved for humanity. Of course, we did have the knowledge that it was a game of survival of the fittest, and yet it was inconceivable to us that these things would fail us so miserably, and for no reason that we could conceive of, perceive, or even see. There was no direct evidence. I mean, what are you talking about? You're talking about overuse of antibiotics. You're talking about antibiotics in the farming sector. Multiple reasons, none of which we could perceive or see. So this is from a common man's point of view. The thing was, even as we discovered that we may not be safe from, even in hospitals or in ICUs, which are supposed to be havens, from vicious bugs. We even at that point, we scarcely imagined the huge implications, ramifications, magnitude of what we were going to deal with. It was just we were unraveling a thread, and we had no clue how long we will be doing this. We're still unraveling the spool. As Sunita Narayan of CSC once said, it's the climate change a proportionate crisis of the world. She called AMR that. So the global, it turns out that AMR, and we didn't know it at that point of time, but that AMR would jeopardize human health on a global scale, and it would cause a great impact that would be inimical to the health and well-being of the human race. Soon it may become impossible to treat simple infections to forget life threats. So this was, as time went past, it was a very, very sobering message. NDM1 was a wake-up call, and as we all know that, stigma followed, and instantly the world turned its guns on the, on the country that supposedly, sent out the highly resistant bug into the world. So all kinds of situations are at play here. Not only do we have, recognition that there is a monster out there in our hospitals, in our communities, waiting to, literally become, possibly the biggest killer ever. But also that, we had to face this onslaught from the West, as, on India. Once again, the old prejudices about India as a, a country that's unhygienic, that's unsafe, and don't go there for, and the deliberate attempt to say that it should not be a destination for medical tourism. So there was much at play at this point of time, if you were following the whole event playing out as some of us did. So what is significant is that, in my mind, at least, in the, reportage and in the attempt to bring to some form of control this antibiotic resistance issue is the Chennai Declaration. And it was a result of the first ever joint meeting of medical societies in India to address AMR. And, I'm sure for the audience that I'm talking to, this is like, carrying coals to Newcastle. But, that Dr. Ghafoor is, one of the architects of the Chennai Declaration, is your go-to person in this case, or in anything to do with this national or state level policy, because he's been, hammering at the doors of the central government and the state governments to push through implementation of very, very, very simple measures that would make sure that there is no, that's a misnomer, but that will make sure that there are at least efforts initiated in order to handle this, in an attempt to handle this huge looming issue. He's also focused on multiple aspects of the AMR in the country. And of course, if you want to learn more, they also have a easily discoverable website. It was much later in 2016 that the UN first discussed antimicrobial resistance at the General Assembly. Earlier, they had discussed about Ebola and HIV as specific cases, but not, antimicrobial resistance as a plague upon humanity. And they also set up the interagency group on AMR to write out a blueprint for taking concrete action that countries would also be able to follow later. So in a sense, since we're talking about Dr. Ghafoor, in a sense, that's how my journey on AMR itself began. And it's difficult to grab the interest of a journalist, particularly someone who does a lot of other beats as well and who has additional responsibilities. But then, there was this, it was very clear that we were sitting on a powder keg that was to erupt at any given point of time, and certainly we had to take action on this. So the first, of course, exposure, the true exposure in the real sense of the term, was with the publication of the paper on NDM1, and then literally 2.5, nearly 3-hour conversation with Dr. Gafoor on the ramification of what it meant and the definitions and what are the things we can do, what are the things we can't do, what does it actually imply, are people dying in hospitals, in beds, are people contracting the infection in hospitals, and well, that's how it began. And of course, there's a load of material available online now. But in the initial days, it was rather difficult to find authentic information on AMR across the world, on concrete studies, maybe community level studies, and particularly in India, there were very few people, in my opinion, doing work at that point of time. Now, of course, it's completely different. What was also different is that unlike HIV and TB, as epidemics that were dealt with on mission mode, AMR didn't have that kind of mollycoddling by the governments or by NGOs or people involved in that sector. Even those who are affected, of course, those who are affected, the victims, the patients couldn't speak for themselves, but broadly, this is the it was a situation then, because I remember when I started out, there was a great deal of media outreach for HIV and TB, about resistance, teaching journalists occasionally about resistance and key points in the evolving, because every epidemic is evolving. That's the nature of the epidemic. And as it evolves, we need to upgrade ourselves. We need to have a continuing medical education on what is happening. And it was easy with HIV and TB, and not so much with AMR. So this is sort of my journey, and I believe, having written about it since 2013, that there is a great deal that needs to be done today. I'm sure all of you will agree with me. And I believe the first thing we should do is to set this issue on mission mode, because that's something that really appeals to the governments. That's how they believe in doing their public health outreach programs. And I don't know what more we should do to tell them that this is not, if this is an issue that's threatening humanity now, imagine how it will be tomorrow. We don't need to run out of drugs that will help our people, that will help save their lives when they really need that kind of assistance. Launching AMR in mission mode is, I think, very important at this point of time. Also, some sort of and implementing the state and national policies on AMR, which we have. Some states do have it too. To implement, to supervise and monitor if these are being implemented well. That's very important. Also, when you're launching something on mission mode, I think it's important to involve the journalists in, more journalists, because those who are writing now basically are health journalists doing it out of interest. But I think you need to widen that pool, bring in journalists who will write on pharma, write on pricing policy, will write on how TRIPS is affecting the drug regime, who will write on the pharma industry and what it could do, people who will write on research and development and international, bilateral, or multilateral relationships for sharing important drugs. Also, I think it's important for the research community to talk about the new antibiotics, the new formulations that are being researched into, and those that will be ready for trial and then for use in the human population. I think it's important to spread that information as well beyond your scientific journals. I mean, it needs to reach the common man. Like a friend of mine, a scientist friend of mine says, whether we like it or not, and I mean, we do like it as part of the scientific community. This has been sort of like the revenge of science. In as much as people shied away from reading content related to health, they are now rushing to read content related to health. And I think we need to, the AMR community, people need to realize this, this desire for learning about health issues and how drug policies affect our health and the community's health, and use it as an excuse to send out information that will be able to, in a sense, counter. In fact, like I said before, the awareness programs that were conducted for HIV and TB, they were able to sort of counter the largely negative reportage that the diseases were getting at that point of time globally. So I believe that it works, and that we need to be able to do that, maneuver that for AMR as well. And, I'm just be, happy to sort of be part of the loop in case people are, setting out important research or just sharing studies that were done in whatever level, at the community level or even locally, because everything, there's a message in everything. I don't think we can afford to forget that message or not read that message and interpret it properly. That's as much. Thank you very much for the opportunity, Dr. Ghafoor, and I hope I can watch a video later of the entire proceedings. Thank you so much.
All right. Thank you so much for that introduction and that primer into this very, very important discussion. And I'd really like to start with Viveka to just get straight off the bat and talk about superbugs. Coming from a screenwriter's perspective, it all sounds very ominous, very interesting, very exciting. You say that as a health journalist, sometimes there are accusations that talking about the superbug is really hyping it up. So can you break it down for us? What exactly are we facing with the superbug?
Yeah, thanks, Adwaita, and thanks, Dr. Ghafoor, for inviting me today to speak on this topic. Our previous panelist, Ramya, has really, already recounted how we journalists, first came across the term superbug when we, heard about the NDM paper. And that was a paper that really shook us up. And we saw the implications of how a microbial infection really took political center stage as well, because, it became a political thing because it got named after a city in India, etc., etc. So what I meant when I said that sometimes we are we are accused of hyping up the problem is that, I remember the time that, a lot of, there was the state government which refused to even admit and lived in denial that MDR, multi-drug resistant tuberculosis cases were increasing. That information was suppressed, and I'm talking about 2011. And when that kind of blew up, that caused another political hullabaloo. And I remember that case very particularly because I happen to know one of the patients who, was part of that study, which of course I came to know much later. So, and I remember the political, rulers of the day were trying to suppress that. The hospital was trying to get that story out, and journalists who were trying to report on the story, uh, you know, were wanted to report on the story because it was of great public interest. But how do you report on a story where the government is denying it, and the government is also accusing that hospital of hyping it up, of not labeling, do not label it XDR TV, it's MDR TV, etc., etc. And those are terms that the doctors on this panel will remember that case. So that's what I meant by saying that we journalists are sometimes accused of hyping up a problem when we keep reporting on it. Now, luckily for me, I do not face that tag because I am with specialist magazines like Express Pharma and Express Healthcare. I'm not with mainline publications, and I'm not competing with, say, a political story of the day or the financial newspaper, etc., for headlines or for space, etc., etc. Now, all that has democratized because we're not talking about a print publication anymore. We're talking about digital. We're talking about Twitter, breaking stories, etc., etc. So I think that whole hype is part of breaking story. I think it is part of the news cycle. I think we've learned to live with that, especially in COVID. Nobody was accused of hyping up COVID. So I think COVID has given us a very good opportunity to, because it's put health front and center, So I don't think that in today's day and age, in the post-COVID era, we would get that same, accusation. So that's where I'm coming from. So if that answers your question, I hope so.
It's very interesting, I think, because there is pushback, and like you said, that your readership is an informed readership. They're familiar with the subject, but then there's also the pharma readership. I'm just curious to know, is there any big pushback, because we hear so much about this very powerful pharma lobby. And you're right, because of COVID, we've heard more about it because of Pfizer and all of those things, where suddenly the general public is so much more aware of these things. How does that work out for you?
So while dealing with the, in AMR problem, where pharma companies come in is that one of the reasons why AMR spiked, why cases of multi-drug resistance spiked, was that pharmaceutical companies were, releasing a lot of effluents into the, water systems where they were manufacturing it. And in many ways, I mean, this was a legacy problem. No one realized until it was too late the impact of those effluents being released into the water systems. Now that entered the whole environment and our ecosystems, etc., etc. And now we are dealing with the fallout of that, especially that's part of the whole climate crisis and sustainability, movement that is there. So I see it as a perfect storm coming together, climate change and COVID, etc., all forcing a lot of industries, not just the pharmaceutical industry, to clean up their act, basically, and clean and green their processes, use better techniques, use better technologies, use better ingredients. Yes, it's going to cost you more money to make that infrastructure shift. So as a specialist magazine, we kind of try to advocate that companies make that shift early. We try to portray the good examples of companies who are making that shift, and kind of hold them up as role models for the rest of the industry. And as Express Healthcare, which looks at the doctor community and the healthcare management community, we again try to hold up good role models of doctors, of hospitals who have good antimicrobial stewardship programs, etc., etc. So that's where we come in, and that's where we kind of, try to influence the talk and the debate about what's going on these things, try and hold up good role models, etc., etc. And we are a free to view portal, etc., etc. So it's not that our viewership or readership is restricted to these groups. There is a lot of Googling that goes on, so we get a wide readership beyond our target readership as well. So I'm hoping that the right people are reading it, and I'm hoping that an investor somewhere picks it up and becomes an activist investor. I think that there is that trend abroad of an activist investor really holding a company to ransom for not doing the right thing. So that hasn't yet picked up in India, but you never know.
You never know. And this brings me to Hina. Hina, this is something very close to your heart, even in your first book. You've spoken about climate change. You've spoken about the kind of pollution. In fact, your story starts with being on the beach. And Viveka was just mentioning, the kind of how does one put it? The pharma companies and what they're putting out into the water. What is your take on this entire issue?
First, microbes are just microscopic bugs. There are trillions of microbes present in our skin, eyes, and mouth, and there are more microbes in our body than our human cells. So there's both good bacteria and bad bacteria. Most bacteria in our body are good. And these good bacteria can help us digest food and absorb nutrients. They produce vitamins in our body. And there are also bad bacteria that can release toxins in our body and can make us feel ill. For example, typhoid bacteria can make us feel ill. COVID could also make us feel ill. But sometimes good bacteria can also create trouble. So for example, during a surgery, when something is wrong with our intestinal wall, a normal bacteria can enter and become bad bugs. So we usually overuse or misuse antibiotics in a way. So bacteria can become resistant to it, and that causes antimicrobial resistance. And so people keep spreading superbugs from one patient to another because we don't keep a hygienic surroundings proper, or we don't wash hands regularly. Even doctors in hospitals, sometimes they don't wash the hands properly, and superbugs can spread from one patient to another. So that way it spreads, and people in a hospital also, they get infection because many people visit a patient and it spreads from one person to another.
And have you been hearing more about superbugs lately? You have, and why do you think that is, Hina?
I think now, since the COVID has ended, I think again people has not started putting hygiene in front of them because they started again not taking care of themselves. And my father keeps on talking superbugs every day morning, so I'm used to it, get knowledge from it. And he keeps on talking about cases that happen every day. So I hear about many cases happening in the hospital, and each people die who was getting infected with superbugs. So that way I heard about it.
Viveka, to carry, like you write for, like you said, a specialist publication, and you said there's a lot of Googling that goes on. A lot of times when I go to my doctor with Google information, he smacks me down and says that, this is the biggest bane in our lives is Google, because everybody is like a half doctor. So how do you think you can, as somebody who's, an advocate, practices advocacy for this particular issue as well as writes in it and on it in a very informed way, how do you think you can get the message across to general people, the lay population, about this issue, and what is not being done and what should be done so that we become more aware?
Thanks, Adwaita. I think all of us need to learn to be patient patients. We've become very impatient patients. I've been nursing this cough since a week. But and we need to find the right doctor. So my doctor has refused to put me on an antibiotic. I'm on hot water. I'm on gargles. I'm on herbal cough syrup, and it has got better. But I was able to take a week off, work from home, etc., and keep away from the dust, etc. So I think we need to take time off. And I'm talking of individual patients, take time off to, let our body heal on its own. And that kind of message has to go out. And at a larger level, I think that message has to be conveyed through the case studies that the doctors have been presenting before our panel discussion. Some of those case studies were truly need to be highlighted, need to be there's a message in each of those case studies, and we have to, as media, kind of put those case studies out there. They were explained very simply. So I think if the general public and if other doctors as well, hear of more such case studies, as Ramya was saying, get out the research that is being done at a community level in India, and as well as also globally, community level studies are being done. The results are now coming out because this has been about a decade in the making that it's come out in public. So I think there is a lot more information that can be shared, that can be put out to the public, and the general public as well as the informed public among pharmaceutical companies, life science companies. There's a lot more research being done on this, thankfully, and also, but what also needs to be done is we need to understand that rather than looking for new drugs, which is going to be very, very difficult to find and a lot more expensive, how do we change our behavior so that the current drugs become more effective? So I think that kind of message needs to be going out more often. Thanks to advocates like Dr. Ghafoor and all, we are getting that. We are getting access to information. One of the points that I also want to make is that the pharmaceutical industry is a highly regulated industry, like a lot of industries. So therefore, they're very careful what they say in public, and I don't blame them because they have a lot of shareholders and stakeholders to also kind of this. And looking at it from their point of view, I mean, this is an industry, whereas Ramya says, they've given us super cures, but we've misused those super cures. And maybe it's not our fault, but we have misused them. And therefore, we've got super bugs. And now we're again turning to the pharmaceutical companies and demanding better medicine. So in a sense that it's everybody's fault. We have to take our onus, take responsibility for our actions and mend our ways and kind of look back. I come back to that, have a little patience, and you don't want to just keep loading yourself with antibiotics just because you need to kind of get well soon. Probably your body is telling you that I need some time, I need some rest, please shut down for 1 or 2 days and then I'll be back. So I think that message needs to go out. I'm putting it very simplistically, but I think that that is a message which the general public needs to hear, and also the medical community needs to feel empowered enough to tell their patients.
No, that's a very important message. And I hear you on that one, because you're right. There is an urgency to get back to normal, right? Every time you fall sick, you're like, I want to get back to normal. And what is normal? Normal means popping pills. Normal means self-medicating, get checked, talking to the doctor on the phone and without a physical exam, and kind of getting what you need. You also, one more thing, and Hina also mentioned it, sometimes doctors don't wash their hands. Of course, that's one aspect of it, the hygiene aspect of it. But otherwise, what role do doctors or do medical professionals realize the role that they're playing in the superbug phenomena? Because you're right, we all have a part to play. We consumers have a part to play when we're so pill popping and happy to do that. But what have doctors realized that what their role is, and what is their role in this whole phenomena?
I think doctors have realized their role. We have to empower them, we have to listen to them. But there's a very important player who is not talked about, and that is the community, that is the pharmacist. If you think about it, you go to a chemist shop, and India is probably one of the countries in the world where the highest number of pills are sold without prescription. And that is your pharmacist, the person behind the counter there, who knows you probably, and you say, okay, I'm feeling this. And, he tells you, he gives it to you. And sometimes, and mostly antibiotics are also being given that way, So I think it's not just the doctor, it's the community pharmacist also who needs to, say that, and it is a tough decision for him, because otherwise, he has a long time customer coming to him, not in good shape. He probably has an important interview, has an important sales call that day, has an important exam that day. So his, urge is to put my customer out of misery and make a sale. So how do we reach out to each and every community pharmacist, each and every pharmacist also, to counsel, to not be just a salesman, but to counsel his person that, okay, I'll give you something, but this is not an antibiotic. Have a little bit more patience, etc., or go to the doctor or report to the nearest hospital, etc., So those are kind of movements, and it's almost a social movement in that sense, where the sensitizing has to be done at each and every link in that chain, in the healthcare, delivery chain, in the healthcare continuum, as the term now is. So I think that, and each player there needs to play his role. So yes, doctors, pharmacists, also need to play their role in a very big way.
What about you? I mean, you have a big exam the next day. You're suddenly down with a cold and cough, and Viveka is saying, be patient, be a patient. But you have an exam, or you have your annual day, and you've been prepping for it for weeks and weeks. You have an in-house doctor in your dad, so you don't even have to go far to get medical help. So what are you going to do? Are you going to pop that antibiotic that okay, in 2 days I'll be fine, I'll be able to take part in this, it'll go away? Or are you going to be patient and wait it out?
Actually, first I almost forgot, but I need to actually narrate my story.
Okay.
So I'll just narrate my story and then
Sure.
So my story's name begin with An Angel at Midnight. A man got out of a car, dressed up in blue short sleeves, top and pant, with a white lab coat. His dark blue tie was loosely worn, spectacles tilted to the side, his greyish-white hair disheveled and shaggy. He wasn't expected at the hospital at 12 a.m. Sunday. The parking lot was dark, under cloudy sky, with occasional dim lights in the gloomy corner. He sprinted towards the entrance of the hospital building, glancing at a watchman who was sitting on a plastic chair, sleeping with his mouth hung wide open. The LED lights on the board on the top of the building flashed. MIG Hospital. The man rushed in and the glass doors opened. He walked towards the elevator and pressed a button to the second floor. His footsteps could be heard far off in the silence of the night. He opened the door of an office, the large nameplate that read, Dr. Arjun Nair. Quickly grabbing the stethoscope, he walked towards the intensive care unit next to his office. The light in front of the ICU was so dim, showing the expression of a few people sitting on a couple of chairs lined up outside. They looked like a family, a man with a dark beard, dressed in plain green t-shirt and trousers, a woman dressed in a sari, barefoot, and a baby wailing in her hands. Dr. Nair pushed open the door. Suddenly, he turned back, listening to the man outside, calling his name. The family who was standing outside behind walked up the doctor. We have been calling you so many times, doctor. Please. Dr. Nair put his hands on the shoulder of the man, as if his gentle touch could wash away the perils of the man and his family. Doctor, please come in fast. He was quickly interrupted by the nurse, who peeped her head out through the partially open door. The doctor patted the shoulder of a weeping man and said, Don't worry, we will do everything possible to save your daughter. Harishma, a girl of 11 years, was on the bed with a blue hospital gown covering her thinned out hands and legs, with a bald head shining in the bright light of the room. A metal bracelet hung loosely on her hand, leaving way for an intravenous fluid line. The temperature records on her bedside chart were sharp and steep at the lining of the mountains. Where's the blood culture report? Inquired the doctor. The team was waiting for the blood culture report from the laboratory. Harishma was diagnosed with blood cancer a month ago. The doctors had given her chemotherapy to cure the cancer. After the chemo, her blood counts were so low and she developed a bad infection. There was little improvement since then. Dr. Nair had injected her with antibiotics that would help destroy the bacteria in her blood. The doctor paced around the room, pulling his tiny spectacles into the proper position and looking at Harishma, who was trying to keep her consciousness still. The printer buzzed, awakening the doctor from his deep thought. The nurses sprang up from their chairs. Within a few seconds, a single piece of paper slid out of the printer. A nurse grabbed it, pinned it on the clipboard, and handed it over to the doctor. He looked at the paper, eyes transfixed, with his hands wiping drops of sweat from his forehead. The nurse shook her head. All of them resistant, sir. Yes, all of them resistant, declared the doctor, his face frowning. The Dr. Nair handed over the clipboard to the nurse. All she saw on the white sheet were bold red R letters and the name Klebsiella written in the bold italic font on the top of the page. No antibiotic can kill the Klebsiella bacteria that was present in Harishma's blood. I'm sure we can do something, said the doctor. Antibiotics have the power to kill bacteria and cure infection. Still, if the results appear resistant to all antibiotics, the bacteria will live and the patient will be in danger. The doctor and the three nurses had no choice but to inform the parents. Dr. Nair walked out of the room to find the family still standing there. Their eyes widened as soon as the doctor walked up to them. And asked the doctor, his voice trembling. His voice sensed hope, but he looks perplexed. The father's eyes welled up with tears, shaking his head in disbelief. No option, the doctor said. Harishma could hear a few words of the discussion happening outside her room. Her eyes softened, falling into deep sleep. She woke up from a dream filled with hope. She read books and characters getting hope and determination. Why not she? Eyes opened, finding herself in a new surrounding, a dream. Walked on the sand, filled with pebble stones scattered around the ground, towards a sea-green river flowing peacefully. She knows she can sit on the riverside every day. Thank you. And also about the question, I would take antibiotics prescribed by my father, and I would be patient. But though I would love to become back to normal.
And that was a very profound story, Hina. I think it really leaves one thinking, and those are the best stories. Really, it does make one think. Viveka, this is all a little scary, right? Because in the common person's, like someone like me, what I'm thinking is my antibiotics are going to make me better. It doesn't cross my mind that I may actually be resistant to this. Why do you think, and someone like me who's very aware, who's involved in current affairs, all of that, reads, watches the news, everything, it doesn't cross my mind that I may be antibiotic resistant. So how do we generate awareness amongst people like me, the common person, to this issue? What are the precautions that we can take? What's the way forward?
So the way forward is that we need to keep repeating this message. Maybe you, through your the films that you do, the people whom you interview in your friend circle, because as you said, we are privileged to belong to a certain strata of society who have come with certain privileges that we have thanks to our income background, etc., etc. And I still remember the case of my son's tuition teacher's son, who was diagnosed with MDR TB, and all of us were shocked. I mean, that person, they come from such a healthy family, and this is 2011, So how can, I mean, this first of all, the stigma that a disease like TB has, that makes it even more difficult for these infections to hide within plain sight, basically. And it's only now that we are kind of talking about it, that certain Bollywood actors are also saying that yes, we've had TB, we've recovered, and becoming advocates for the disease. And I think AMR needs a kind of advocate of the standing of Mr. Amitabh Bachchan to really, who galvanized the polio campaign, because there was a lot of resistance to taking the polio drops too. That too is a long drawn out campaign, etc., etc. So somebody of that standing who kind of galvanizes, action on this front. Governments are being forced today to do it. The One Health approach of WHO, etc., etc., which says that what's good for health for all communities. It's not just antibiotics need to be reduced not just among the human population, but there's also the poultry population, which is given a lot of antibiotics to keep disease down, and then that enters our food chain. So we are becoming resistant also because of the kind of meats that we have. The milk that we have has high antibiotic levels, etc., etc. So it has to be a concerted effort. A lot of government departments are involved with that. It's going to take a lot of time to kind of erase our bad steps of the previous decades. But I mean, I don't want to sound too negative, so let's start now. A start has been made, and it's going to be a long way. And I just hope that we don't give up. And actually, we have no option because we can't give up. So, I mean, that's the message of today's, that's the message that I choose to take from today's webinar, that I'm very happy that this is being talked about, that, this is the way to go forward. We need multiple doses and of hearing these messages, of amplifying these messages, holding up good role models of people who are trying to do something about it, etc., etc. Keeping track as journalists also of, or as media people, of what government is supposed to do. For instance, a lot of states have not yet signed the AMR laws that they are supposed to put into action. A lot of them who have signed them into laws have not implemented it. So those are the things which need to be really tracked, etc., etc. That and hold government accountable, hold our doctors accountable, etc., etc. So I'm as a media person, I'm very happy that I chose not to do science and write about science, because I feel that that's also important to kind of train the next generation of journalists to write about these technical topics, to find good sources like Dr. Ghafoor and his AMR Trust to give us the right information, to give us authentic information. There's a lot of bad misinformation also going around. So a lot of training needs to be done. As Ramya said, continuing medical education for doctors and continual training of journalists to report rightly, to report on the issue properly. And I hope that, people of your standing also take up the message to the larger masses in a manner that is, more interesting for them. I mean, movies like Padman and all addressed menstrual health so well. And I'm quite hopeful that your generation of media people in and script writers, these kind of ideas from science enter the scripts of today and tomorrow's movie serials and TV serials and also films.
That's food for thought. I must chat with Dr. Ghafoor offline about the possibilities of that, because I think that would be very interesting. Apart from we are infotainment, what we call infotainment. That's a powerful tool to spread awareness.
Absolutely, yes.
Hina, what about your dad is very passionate about AMR. So you are in a unique position, so you get to hear about it at home, what it is. What about kids your age, the next generation? How aware do you find your friends, peers, when it comes to this issue?
I think most of my friends and school students are not aware about this problem. And so our school sets up all these other things that can help create awareness against children. So as a school student, I believe doctors should not give patients antibiotic until absolutely necessary. And we children, adults also should not buy antibiotics without a doctor's prescription. We should not use antibiotic as prescribed by the doctor to your other family members. So I think we should also encourage taking vaccines since it can help reduce infections and antimicrobial resistance. And so all schools should teach how students how dangerous superbugs can be and how can we tackle superbugs.
That seems like wise advice. Dr. Ghafoor, let me invite you back. We have about 5 minutes to go. And if you'd like to make any contribution to this very interesting conversation that we've been having, what are the things that we can do as normal people to ensure that we don't develop this sort of resistance?
Thank you, Adwaita and Viveka, Hina and Ramya for an excellent discussion. The media can play an excellent role, an important role in educating the public and convincing the policymakers to act to control the AMR crisis. Without media, we so-called experts, cannot communicate that message to the public. And without public support, we can't convince the policymakers. Without media, we can't communicate the policymakers. You media people, the media are so important. And you should all, and media in India have done an excellent job, I have to say. Over the last 10, 15 years, media played a great role in convincing the public and policymakers. And our government did a lot of very good things, a lot of policy changes. And we are talking about a country, a big country, 1.3 billion population, so many states. Ours is and AMR is a complex socio-economic challenge. It's not just a scientific challenge. And our government have done very good steps. Only thing is not seen really on the ground because of the enormous size and the complexity of our country and the complexity of the AMR challenge. And we can do a lot. We can do a lot with help of media, with help of public, with help of experts, hospitals, pharmaceutical industry, and everybody come forward. We can make a lot more changes in our country. And our country has the capability, the strength, and scientific community strength, pharmaceutical community strength to develop new antibiotics, to develop new diagnostics, to develop new vaccines, and all the other scientific technology to tackle the challenge of antimicrobial resistance. And you media should help us and the country more. Of course, you've done a great job, more towards achieving this target.
Okay, on that optimistic note, and the sense I'm getting is that this is a journey, and we're sort of in the infancy of that journey, and there's a long way to go. Because you're right, we do have many challenges. I can say I'm guilty of it as well. Going to my chemist, like Viveka was saying, and saying "Sir mein dard ho raha hai, bukhar sa lag raha hai, give me some medicine," and then he'll just pull out something and give it. I think we all, for the convenience of it, for the familiarity of it, we all tend to misuse it, although not all of us, are doing it with any ill intention. Most of us are not really. We're not, pill poppers in that sense that we get a high out of it. We're just doing it because it's convenient, it's available, and there's a trust element also in that interaction involved. So I think we need to also get ourselves on the path of behavioral change as consumers. I think that's very important, because you can have all the laws in place, but if that behavioral change isn't there, I think we're going to be stuck with this problem for a long time to come. Thank you so much again, the AMR Foundation, for giving me this opportunity to educate myself, to learn so much more. I feel truly blessed to have had this opportunity to learn so much about this subject, and it's definitely going to make me more cautious in the future. And over to you, Dr. Ghafoor, and thank you, Viveka. Thank you, Hina, for a very enlightening session. And I really enjoyed our conversation. And we are, I guess, partners in this journey. You've certainly convinced me. Over to you, Doctor.
Thank you, Adwaita, Viveka, Hina, and Ramya. We will move on to the next session, and Dr. Ashwini will coordinate the next fire chat session. Ashwini, over to you. Dr. Suresh will be the first speaker for the session, the super salmonella. Suresh?
I don't have the video. I don't have the video access to me there. So ask them to provide video access to me, sir.
Okay, I will do that. I will do that.
Yeah, they start now. Yeah, correct. Yeah.
Okay.
Yeah, so I'm able to see now. Yeah. So there's no need for any further introductions. I think Ashwini and Priscilla is busy. So because of running out of time, we can start the presentations. I think Priscilla has joined.
Priscilla, you're joined. Yeah. We just started, Suresh is on board.
Okay, I think somebody needs to unmute me.
Yeah, you're audible.
Okay. Yeah, sure. So, good evening, everyone, and thank you for inviting me to be part of this program. And it's absolutely my pleasure to moderate this session. And this is a wonderful initiative by the AMR Declaration. So, I think we'll go ahead with the first talk, which is by Dr. Suresh, and the session is called the Super Salmonella. Very, very interesting case title, and I'm sure we're going to actually have an excellent session. Over to you, Suresh.
Specifically, the organizers don't want to use slides for me, but without slides is a bit difficult for me. So bear with me with my couple of slides only, but I'll finish within 7 minutes time. So this is not no options typhoid. This is no oral options typhoid. So this is case of typhoid Mary. This is not typhoid Mary. This is typhoid Ronnie to me there. The patient name is some Vidya Rani or something. So I make it as a typhoid Ronnie for you. So certain things we can't get answers from disclosures from. Certain things we cannot answers from Google. For example, what is the best antibiotic? Right now, couple of computer decision software system is available, but still none of the system is efficient to provide answer to me, which is the best option to the patients. We need practical experiences. We are dealing with this no options quite some time. My previous speakers were alluded on it. There is no good options, but we got a lot of experiences, but our experiences is not saving all the lives. My experiences is not protecting all the persons. So I begin with a case here. She's a 22-year-old male. She's a 22-year-old female, basically from rural part, but now settled in Chennai. She got a dream to do her master's in US. Her name is Rani, 22 years. So she got the visa ready. She's supposed to move in a couple of weeks' time to US. That point of time, one day, suddenly she started developing fever, some abdominal discomfort, loose stools, diarrhea happened. So immediately what happened, my previous panel discussed, she tried to self-medicate with some paracetamol, some Bifilac also. This is called probiotic. So because of the diarrhea, she started taking some probiotic along with paracetamol. Couple of days, the improvement happened. But next 2 days, again, the fever is coming back. Fever is not subsiding. This time she decided to go to chemist. She went to the chemist. The chemist has prescribed some antibiotics, not only paracetamol, not only anti-motility drugs. For example, loropramide. That's a drug we will commonly give for anti-motility. In addition, the chemist given azithromycin because he copied the prescriptions of the local physician. So she started taking these drugs. Next couple of days, she's all right. Slightly showing some signs of improvement. Fever is persisting. The abdominal discomfort has come down. So she started her work again. But unfortunately, from day 3 to day 4 onwards, again, the fever started coming back. The intensity of fever is shooting up. Previously, it was low grade, 99 to 100. Now it's stretching up 101, 102. The discomfort is also persisting. This is a time she decided, I need to go to a doctor. So she consulted a doctor. The doctor asked the history. You got fever, you got diarrhea. So he prescribes one of the commonly prescribed antibiotics by the most of the general physicians is norfloxacin plus tinidazole or hornidazole. That's the combinations people are using it. Even though if you see, the combination is not tested. Individual molecule is tested. But unfortunately, for the sake of convenience and sake of prevention, they use the combinations, but without writing a diagnosis also. Most of the physicians in this part of the world, they don't write what they think, they don't write. They write the treatment, but they don't write what they're thinking, what is the diagnosis they're thinking, what are all the possibilities they're thinking in the mind, they don't write. So what happened? The doctor has given the prescriptions. The symptoms was not subsided. So she went to other doctor. The routines of our patients, within 1 or 2 days, they need to improve. If the doctor is not given injections, if the doctor's medicines is not doing the trick, they automatically go to the next doctor. She went to the next doctor. This man prescribed some couple of tests, along with change the medicines. That is a routine. When the previous medicine is not working, he changed the medicines, but fortunately within the same group called ciprofloxacin. He gives ciprofloxacin, he made 2 to 1. That's the concept we are talking about. We need to keep minimum of antibiotics. So he did the trick, but he kept the same family, ciprofloxacin. With ciprofloxacin, 3 days of medicines, her symptoms is a lot better. Her temperature again coming back to 99, again low-grade fever, pain is subsided. She felt she has cured of the disease and she felt this clinician is much better. So what happened? Again, she started moving to a job. That point of time, again, fever strike back within a week's time. This time again, intense pain. The pain is getting more. So she can't tolerate. So she went to the hospital, get admitted in the emergency, got in the emergency room. In the emergency room, her fever spikes is very high. Temperature is spiking. Pain in the abdomen is very much high. And she passes blood in the stools. This point of time, blood in the stools. So something going wrong. So they started investigations. Previously, the outpatient doctor did some test called Vidal. That is an old, outdated test. Unfortunately, people still doing to make a diagnosis of typhoid. So this person went to the emergency room. They asked for cultures. This is a standard dictum in any fever that lasting more than 5 to 7 days. We need to culture the blood. If you do the cultures, we can get the organisms. Same thing happened to her. The culture came back in 2 to 3 days time as Salmonella typhi. But the problem this time, it is usually what tendency of typhoid in India or typhoid across the world, most of the antibiotics will work for typhoid. Any antibiotic will work except the antibiotic prescribed by the doctors like norfloxacin and ciprofloxacin. Of late, the resistance has come back. That is why WHO has put priority list for the typhoid. Typhoid is emerging, particularly the fluoroquinolone, what the antibiotic I told, ciprofloxacin, norfloxacin. This is the easiest antibiotic. In 1970s, 1980, when the doctors struggled to treat typhoid, this magic bullet came in 1970s and 1980s. 1980s, this molecule came as a magic bullet, cleared the typhoid fever immediately. But unfortunately, it is resistant nowadays. It is not working. Apart from this antibiotic, most of the antibiotics were working. That is the scenario in India. Unfortunately for my Rani, none of the options, like commonly used antibiotic like azithromycin, third generation cephalosporins we call, cefixime or ceftriaxone, people might have aware. So these antibiotics are common bread and butter for typhoid, is not working. One is oral tablet, other is once a day injections, very cheap injections also, very not costly. Unfortunately, these medicines was not working. The report shows most of the things is not working. Highest and powerful antibiotic like meropenem. This is the most powerful antibiotic. We usually reserve for a patient in ICU. That antibiotic is sensitive. So we started with the antibiotic called meropenem, but unfortunately, despite meropenem, our pain persisted and our blood in the stools is persisted. It's called dysentery. So finally, the surgeon came and we tested some imaging done and we opened up. It shown hole in the intestine. That's called perforations. Perforations of the intestine. In modern era, 2020 onwards, we are not seeing these complications. 1950s and 1960s saw a lot of intestinal perforations, hole in the intestine caused by typhoid. That is the dreaded complications. But with the advent of good antibiotics, the perforations is not seen. But 2023, again, we came back and saw typhoid resistant to common antibiotic, at the same time putting a hole in the intestine. This is the most dreaded complications we see typhoid. So this is not a, this is not a no options typhoid. This is no oral options typhoid to me. When a patient comes with this car, at least I don't expect to go back with the same car, but not this mode of communications, because this communication is not existing in India right now. So we need to send, even though the patient survived, the patients underwent surgery, the patients treated with meropenem, 2 weeks of meropenem, costly antibiotics, the patient spent a lot of money. We saved the life of the patients, but he lost a lot of money and a lot of suffering. The suffering we can't control. As a physicians, we need to control the suffering of the patients. Unfortunately, the suffering we can't control. And easily treatable typhoid with the oral tablet we treated, but unfortunately, we are not able to treat the patients. So we need to treat infections like a war. We need to know our enemy and we need to use our pug or weapon. Our weapon to be judiciously, but unfortunately, we don't have a good weapon to our enemy. So if we know everything, who is our enemy, where is the place it's happening, what is our bug, what is our drug, we know, we will beat the enemy. But unfortunately, we don't have good weapons nowadays. That is a problem we are facing. So this typhoid is not no option. This is no oral options. It killed the dream. The parents cancel the visa. The parents cancel the tickets. They wanted her to stay next minimum 1 year. They want to postpone. I do not know whether it's indefinite postpone or not. So the resistance not only kill the patients, the resistance kills the patient's dreams also there. Kills the dreams and makes the patient suffer. So don't take antibiotics. Well, no antibiotics will kill the patients. No antibiotics will kill the dream of the patients, make the patient suffer. So those who want to learn more about infectious disease, this society is also helping you there. Thanks for the wonderful opportunity. I hope I stick to the time of 9 to 10 minutes. Thanks for the wonderful opportunity. I just stopped sharing my slides.
Thank you, Suresh. That was an excellent summary in the few minutes. And you're quite right. We actually do have an impossible situation where a common disease like typhoid, unfortunately, has the chance to have no oral options. So thank you very much for that summary. Is there any questions from anyone on the fireside chat? Any questions, any comments? You're absolutely right. I think India is the typhoid hub of the world. And as you know, typhoid resistance it actually seems to, the H58 haplotype actually spread from India to the rest of the world. And the Indian subcontinent has to wake up and do something about it. And thank you for letting us know about the various other options that are there. So you're absolutely right. Oral options, yes, we only have azithro for the time being. And unless we all use the antibiotics we have wisely, we have, unfortunately, a situation where we will lose the only oral option of azithromycin that we have available to treat typhoid on the Indian subcontinent. Any questions or comments from anyone around? Okay. So I think there's a good question from Dr. Raksha. And Dr. Raksha mentions most of these specialists, whether they're ID, pharmacology, microbiology, have CMEs, and they don't really have any kind of interaction or communication with one another. And how do we address without collaboration? Do you have any thoughts about this? And I think, Suresh, this is a general question. Anybody else is also free to answer this.
A lot of things coming up. No, you are the society's secretary there. Since Infectious Disease Society in India has got a society, and Priscilla is a secretary at this point of time. And Dr. Gafoor is working on the Antimicrobial Research Trust. And I am working with the best of ideas. This is a small startup there. So a lot of interactions medium we people provide you there. As a society level, as an individual trust or individual setup, we are doing a lot of providing. Only thing we need to have interlinking is missing. That's what we are working on it in the future. What you say, the crosstalk is going to happen. We are trying to improve our individual person as an individual ID person. We are working on it. And similarly, the society is also working on it. So we can provide, but we need to provide opportunity. We need to provide time and we need to interact. It's possible that we start emerging, but we need to go in a bigger way. Definitely, it's possible with everyone's stepping in. I think Dr. Gafoor might provide more information this one.
Gafoor, do you want to just make a comment quickly before we go to the second speaker?
Oh, no, we'll discuss at the end of the session, Priscilla.
Okay. Yeah, we can do that. All right. So we do have a couple of questions which we will hold to the end of the session. So we'll go on to the next speaker, the topic being a transplant saga and the super CMV. We've been hearing about bacteria. Now let's hear about a different kind of patient population and a virus which we all dread. So it's my pleasure to introduce Dr. Vasant Nagavekar to the group. Dr. Vasant is an ID physician from the Leelavati Hospital in Mumbai. And Dr. Vasant is also the upcoming Secretary of the Clinical Infectious Disease Society of India. So handing over to you, Vasant.
Yeah, thanks, Priscilla, for that kind introduction. I think I have a recorded talk and I'll be listening to that.
Okay. Mayank? Okay.
Good evening, everybody. I'm Dr. Vasan Nagvekar, infectious disease consultant at HN Reliance Hospital and Leelavati Hospital, Mumbai. Dr. Ghafoor has taken a great effort for this no option, and I think every person in India should know that we are going through an extensive resistance problem, not only in bacteria, fungal, but even viruses. And I'm going to tell you a story about cytomegalovirus resistance and how difficult it was for the family and for all of us to get this medication. So here we have a 27 years male person who had acute fulminant hepatic failure, who was transplanted, live donor liver transplant. And after the liver transplant, he was doing well. He did have some CMV viral load copies. And so he was put on prophylactic valganciclovir. So after starting him on valganciclovir, his CMV viral load copies had come down. And then he was, after 4 weeks of this treatment, the valganciclovir oral tablet was discontinued and a preemptive approach was approached. He was discharged only to come back after 1 month again with liver enzymes rising in a post-liver transplant. So that's quite a serious issue. And he had fever also. So he came with fever and he came with liver enzymes which were increasing. Okay, so the possibility is normally whenever you have liver enzymes increasing a liver transplant patient is that it could be infection, which was ruled out completely. There was no evidence of sepsis. Was it a rejection or was it something else going on? So we did his liver biopsy, and the liver biopsy showed that he did not have any rejection, but he had CMV inclusion body seen in the liver tissue. Plus his CMV viral load, which was done in the blood, was around 1 lakh copies. So we were good. So we started him on IV ganciclovir, and we thought we would be able to, get over this. So we started him on IV ganciclovir 5 milligram per kg. So the drugs which are available in India to treat a cytomegalovirus as of now is only ganciclovir and oral valganciclovir. So we do not have other drugs like foscarnet, cidofovir, maribavir, or letermovir, which is used as a prophylaxis. So we started with this treatment, and we thought over a period of time he would respond to the treatment. So his liver enzymes from 500 become 700 on treatment. We waited. We thought he would respond at some point of time. So at 1 week, his liver enzymes went up to 900 plus. So we still thought we give some time. And at the end of 2 weeks, his liver enzymes went up to 2000 plus. So cidofovir and foscarnet is really, I would say difficult. It's very difficult to procure in India. And maravir and your letermovir is not available in India for sure. So it was really difficult. So at 2 weeks, we saw that this 1 lakh copies of cytomegalovirus became more than 5 crore copies. So then there was something wrong which is going on in this patient, and we increased the dose of ganciclovir to 15 milligram to 7.5 milligram per kg 12 hourly, and we repeated the viral load again after a week's time, and we saw that the liver enzymes had gone up to 2000 plus, and the CMV viral load copies were still more than 5 crores, and he was just not doing well. He was clinically. So at this juncture, it was very difficult to get the foscarnet. The only choice was either to use cidofovir or whether to use foscarnet. Cidofovir is it's quite a nephrotoxic drug, and so is foscarnet, but foscarnet is more friendlier to be used. We procured foscarnet from we couldn't get it in India, so we got it from abroad, and the costing of it is around 70 to 80,000 rupees per day, and we may have to give it for 3 to 4 weeks. So it's quite a serious issue for the doctors also to explain to the patient and the acceptance of the relatives for this treatment. But for some reason, the relatives could get the foscarnet from internationally, they could procure it, and we started with the treatment, and only to see that at the end of 1 week, from the 5 crores copies, it came down to 1 crore, and after 2 weeks, the viral load came down to 4 lakh copies. So from 5 crores, it came, and the liver enzymes came down to close to 100, and the fever disappeared. So this patient did respond to foscarnet, this treatment, and he's clinically doing well. But the whole question is not that this patient is done well. The problem is that the resistance, one is we don't have in India easily resistance testing available for cytomegalovirus, which is the two genetic mutations are the UL54 and UL97. That is just for theoretical background. But the whole thing is that this patient got better. But what is more important is that we in India, if suppose this patient couldn't afford or we wouldn't have been able to achieve this foscarnet for some reason, I think we would have had a bad clinical outcome of these patients. And I'm sure similar patients may be having across India, and then we have no options but to let this patient not do well. So we are just left with only ganciclovir. So across the world, when foscarnet and cidofovir and maribavir is available, I think it's India to take the lead to manufacture not only these drugs but maybe invent in more to get into more invention of other cytomegalovirus drugs available to be made available, or to make more research on this subject in India, so that we have more available options for our Indian population. And because now transplant, whether it's a stem cell transplant or solid organ transplant or other immunocompromised condition, I think we are seeing quite significant cytomegalovirus, and it's high time that we should move away from having ganciclovir. Of course, is the best weapon we have, which works in more than 90-95% of the patients, but then 5 to 10% of the patients, we do require foscarnet or cidofovir or maribavir, or maybe we should have an option instead of valganciclovir to have letermovir as an option. So this case illustrates how difficult we went through this patient, but luckily this patient could afford that foscarnet. But I'm telling you, it's very difficult. 50 to 80,000 rupees per day. We gave it for 4 weeks, and now after that also is the big question mark, because most likely this patient must be having a ganciclovir resistance. And the question is that how do we further prophylax? The only way to prophylax would be to use possibly letermovir, but again that drug is not available in India. So I think it's high time that India, we have these drugs manufactured in India by our Indian companies, so that it's made easily affordable to the patients. And also we have more research on these viruses, cytomegalovirus, HSV, what are the various options available, not only the treatment options, but I would say even investigation-wise to find out the resistance of this genotypic resistance, as well as to have the antiviral drug resistance for our patients. I think we should much move ahead of time, what is along with what is happening in the Western world in the medical ethics. So I think this case illustrates how difficult it was for us to get these patients out. Thank you so much for your kind attention.
Thank you, Dr. Vasant, for bringing home to us another common clinical problem we face. And ganciclovir resistant CMV is difficult to diagnose, not just difficult to diagnose. After that, we really have issues with procuring available treatment options. So it's not just CMV. Actually, when we face problems with ganciclovir, whether it's for other drugs, for other bugs like parvovirus, we have the same problem, and foscarnet is actually not available. It's much more toxic and can be very, very expensive to actually import for our patients. So indeed, another fantastic example of where there are no options, clear-cut options that are available. Now we'll go on to our third important and interesting title, Superbugs and the Money Heist. And it's my pleasure to introduce Dr. Saurabh Pandey. Dr. Saurabh Pandey is a senior consultant in the Department of Critical Care at Max Super Specialty Hospital, and he's also the coordinator of the AMR section of the Indian Society of Critical Care Medicine. Welcome, Dr. Saurabh, to this session, and we look forward to your talk.
Yeah. Thank you very much. I would just like to thank AMR Declaration, Dr. Gafoor, and just correction in the introduction. I think my next speaker is Dr. Saurabh Kumar Das, who is a consultant of critical care medicine. I'm a consultant physician and an ID specialist working in Gorakhpur, Uttar Pradesh. And I'm here to narrate a case from a rural background. So we generally don't get to have the vision of a rural background. So we had a 60-year female, was a known case of diabetes and hypertension, and she had urinary tract infection. Right from the start at the rural center, she was prescribed antibiotics, 4 in number, without sending any basic investigations, was treated for 5 days. Since there was no big relief to the patient was referred to private hospital where I was working in the city. So we assessed the patient and then we sent the blood culture of the patient as well as the urine culture. Then we found that the patient had community acquired multi-drug resistant infection of the urine, and she has begun to develop pus around the kidney. So at this point of time, this patient who was middle class, rural background, without any insurance coverage, had to put on a treatment that antibiotic alone worth of 12,000 per day. Over the next 4 to 5 days, there was minimum improvement in the patient. So we stacked up our antibiotics, following which by 5th to 6th day, the patient began to have marginal improvement. But as we know that we are facing multi-drug resistant hospital acquired infection at the same time, this patient unfortunately developed a pneumonia which was hospital acquired, and it was resistant to the known antibiotics to us. That is, it was a colistin resistant Klebsiella. So we decided to put patient on Astrinam and the modern antibiotic in form of Zevicefta. The alone cost of this treatment was 20 to 25,000 per day. Under such circumstances, the patient without any insurance coverage began to become hopeless regarding their financial status. And therefore, the patient asked us about the prognosis of the patient. The patient who was already recovering from a multi-drug resistant infection developed an overriding multi-drug resistant infection, and the cost of the treatment doubles. Therefore, after 3 days of treatment, the patient requested us to let the patient go. And after 9 days of treatment at our center, the patient had to go because she had no other option left. In this regard, we advised the patient to visit the nearest medical college, but the patient attendant had become so hopeless with the amount of money that was spent and the minimal improvement they found. They preferred going back to home. So the impact of high drug resistant organism on the families could take them to a level of denial that they even do not go to a center where they can put their patient back to work, back to life, and the cost of care that will be provided at the highest government institution is far less. So, with this, I would like to put up 3 points. The middle class of India, especially who are not covered by any insurance, tend to avoid the government setting, preferred going to the private setup, but at the same time has limited financial cash backup with them, and they easily land up into a financial crunch. Second point which I would like to add is the present PMJY Yojana, that is Ayushman Bharat Yojana, have to focus on providing separate package for MDR organism infection. Thank you very much.
Thank you, Dr. Saurabh. We have chicken food for the soul, and we also have Dr. Ghafoor next talking to us about the chicken diaries, the colistin-resistant superbugs. So over to you, Dr. Ghafoor, and Dr. Saurabh Pandey, please remain with us, and we'll take questions after.
Dr. Priscilla, instead of me, Dr. Saurabh Pandey will be present in the case. I'm not a panelist. We have changed the session. Sorry.
Okay, so in that case, then we will move on to the next person and the next present.
Yeah, can I interrupt?
Sure.
Yeah, ma'am, there is Dr. Saurabh Kumar Das. Was the last recording that was going on was with me or Dr. Saurabh Das?
It's okay. Now next will be Saurabh Kumar Das.
Okay, thank you.
Thank you. There's lots of confusion. Saurabh Pandey and Saurabh, we both shared our name and shared a topic also. So anyway, thank you, Dr. Ghafoor and Dr. and AMR Declaration Trust for giving me the opportunity to participate in this webinar. So, since the topic is same, I would tell you another story. And this story is about a boy called James, and he is around 20 years old, and he was from my native place, Guwahati. He was not very good at studies, but was a brilliant singer. Naturally, he was extremely popular in his college. One day, he told his father, "Papa, I get tired very easily for last couple of weeks." The father took him to a doctor. The doctor did some tests, and they found that his hemoglobin was very low. It's 5 gram, only 5 gram per deciliter. So he was referred to a hematologist. Again, some tests were done, including bone marrow biopsy, and they found that he has some leukemia. This news was a bolt from blue for the family. The doctor advised him for bone marrow transplant, but his father was a teacher, and it was difficult for him to bear the huge cost of the treatment. He sold some of his ancestral property, drew money from PPF, and they came to Delhi. Before coming to Delhi, James was having some urinary tract infection, for which he took some injectable antibiotics. In Delhi, he was admitted in a corporate hospital and underwent several tests. The doctor in Delhi also advised for bone marrow transplant, and they told the family that this transplant might cure James from the disease. So bone marrow transplant was done, and the post-operative period was uneventful till 3rd day. The family was hopeful that they would go home very soon. On the 4th day, James had fever, and samples from different sites were sent for culture and sensitivity. Empirical antibiotics were started. Unfortunately, he was not responding to the treatment. He was shifted to the ICU, and he developed respiratory difficulty, for which he was put on the mechanical ventilation. His kidney started failing, and for which dialysis was started. His medical bill far exceeded what was initially estimated. James further started taking loans from whoever he could. Back home, James' friends started collecting money by crowdfunding. But this was not enough to meet expenses. James' family did not have any option but to sell their house. The hospital doctor informed that James' blood culture grew a bacteria that was resistant to all antibiotics that were tested. So a combination of antibiotics were tried with the hope that the combination would work, if not alone. His condition did not improve for several days, and antifungal was also started. Blood pressure started falling, and he could not tolerate conventional hemodialysis, so CRT was started. But there is no sign of recovery. James fought for long 32 days, and in the early hours of 33rd day, James breathed his last. James' family was devastated. They sold whatever they had. They didn't have even money to transport the mortal remains of James. The government and the social agency came forward to help them, and finally they returned home with lots of loans to repay, memories of James, but no home to stay. This story is an unfortunate but not a rare one. Cancer and its treatment lowers immunity and making them prone for various infections. These infections are often caused by multi-drug resistant organisms. The infection increases morbidity, hospital stay, need of organ transplant, need of second line of antimicrobials, need of increased duration of antimicrobial treatment, and thereby increase the cost of treatment exponentially, which is already very high. It is difficult to calculate the cost of treatment attributable to antimicrobial resistance. However, in recent times, there are several cost analysis studies were carried out in patients infected with MDR organism. In USA, a retrospective analysis was done, and it was found that due to the methicillin resistance Staphylococcus aureus, the cost increased by approximately $30,000, and for carbonum resistance Acinetobacter, the cost increases by $74,000. Highest attributable cost for community onset invasive infection were seen with carbonum resistant Acinetobacter, which was $62,000. The cost of treatment of MDR infection was estimated to be 4.6 billion in USA in the year 2017. According to CDC, in the United States alone, the antibiotic resistance could add about $400 to the hospital bill for treating patients with any bacterial infections. CDC says that antimicrobial resistance add $20 billion surplus in the direct healthcare costs in the United States. According to different studies, it is projected that AMR could cost from 300 billion to 1 trillion annually by 2050 worldwide. We have also few national data regarding the cost due to AMR. A recent study by Sinha et al. They found that in health economic market activity treatment in Mumbai competed the individual could spend 2 years and of his total income to get rid of TB, MDR TB. One family who was part of the study spent 25 lakhs in 2 years to purchase for ATT, to spend for doctor fees, hospital stay, etc. One study calculated that treatment cost of MDR TB approximately was 6.5 lakhs, which was quite high for many Indian families. Catastrophic cost, which is defined as a cost more than 20% of annual family income, was expressed by 7 to 32% of drug sensitivity TB and 68% for MDR TB. A statistical model estimated that human consumption of antibiotics in India would be around 20 to 22 million doses per year, and economic cost due to the AMR would be around 640 to 700 billion per year. Thus, AMR may host at least 0.5% of total Indian GDP. Thank you.
Thank you, Dr. Saurabh Das. I'm sorry, I think I'm the one who got your names mixed up. So we will go ahead to the next speaker, Dr. Rajlakshmi. Dr. Rajlakshmi will be talking to us again about two interesting cases, a zombie Zika and a food platter from Delhi. Dr. Rajlakshmi is an ID physician from KIMS Health. She's also the AMSP and the infection control lead of that particular hospital, and she's very recently concluded a successful AMSP workshop in Trivandrum. Over to you, Dr. Rajlakshmi.
Thank you, Dr. Priscilla and Dr. Kafus for arranging this meeting, and I think it's a very, very important one. And the topic that is I'm going to talk about is zombie Zika and the tiny head. And probably by this time you would have guessed what the tiny head is. India is endemic to variety of mosquitoes. You name a mosquito, it will be there. So it's very, very important that vector control plays a priority, because most of these mosquito-borne illness doesn't have a proper treatment. So if you largely divide as mosquito-borne illness, in India, malaria is very common, you all know. We have treatment options. And the other important, and it is caused by Anopheles. And the second important large group of mosquito which can cause series of illness, viral illness, or the Aedes aegypti type. And India is all over, it's common, it's very, very common all over India, but it is also seasonal. So we should be aware of how to prevent this mosquito-borne illness. Why I'm telling is, there's no great treatment option. Many are symptomatic supportive measures. There is no good vaccine as such. So if you ask me, what are the infections that is caused by this group of mosquitoes? It's commonly causes dengue fever. And recently we have had cases of Zika. That is what I'm going to talk about. It also can cause yellow fever and chikungunya. So a mosquito can spread several viruses depending on what it carries. And frankly, none of the 4 viruses that I've spoken about, what this causes, none of it has antiviral medicine. And certain infections can be serious. For example, dengue can bring in a patient to the hospital if they have severe hypotension, bleeding, or a low platelet, and sometimes patient may even die of dengue. So it's important that we be aware of mosquito-borne illness, because it is a public health measure to prevent vector-borne illness by reducing the vector load. But it is also important from the person, as a personal aspect, to have a clean surroundings, which is dry, which doesn't promote mosquito breeding. So this is very peculiar in the sense it actually it's an indoor mosquito. So you need not lie outdoor or go outdoor to get this mosquito bite. It may come in, and within the house, if you have any waterlogging or any water, even pots which there is a waterlogging, or small cups which is not drained properly, this mosquito can breed and it bites during the day. So it's important that we are aware of this. And Zika, you may think it is a mild illness. Generally, yes, but in pregnancy, it can be a serious issue. Because when we had the Zika in 2021, among the COVID outbreak, we had this confusion coming with viral fever, like illness and rash, joint pain, and some had red eye. Then we initially suspected the common things because Zika was never reported in Kerala at that point in time. So we never thought of Zika because we know it could be measles or something. We evaluated and finally we made a diagnosis of Zika, which is a surprise. So then we have a new disease coming into our state. So this is been reported in Tamil Nadu, in Rajasthan before. Unless you control, you will have a recurring problem, and then this becomes endemic. So when it is occurring annually, like dengue is endemic, then you have a problem if it affects the pregnant women. So in generally, otherwise, it is a mild illness. You give symptomatic measures like paracetamol and you're better. But in pregnant women, it can affect the child, the unborn child, and then they can develop small head called the microcephaly. So we had an extreme panic among the pregnant women at that point in time, because many could recall some mild viral fever with rash few weeks ago. So they were queuing up for scanning, and some even opted for abortion. So that is some amount of mental trauma that it could cause, even the illness is mild in specific population. So I'm bringing it up, this as an important thing, because this virus doesn't have a great treatment to cure. If it causes severe illness in adults, sometimes it can cause neurological illness called the GBS. We don't have a good treatment even for pregnant women. It is all preventive. Second is, we don't have a vaccine in hand as a preventive measure. So it is all about vector control. It's a public health measure as well as at the personal level. We should all take care of good sanitation and hygiene, keep our environment or our surrounding within an immediate surrounding, not waterlogged and dry. Especially this can be post-seasonal like a monsoon. So you have to be extra careful. And people may incur loss of work hours, school days, as well as sometimes debilitating joint pains. So prevention is better than cure. Thank you.
Raji, do you have a second case for us, the double whammy of a food platter? Please do go ahead with it. Thank you very much for talking to us about Zika and the cases that you've experienced.
Thank you. So the next case that I'm going to talk about is another tragedy. So this young girl, it's a real story. It's a young girl who went to North India for a short trip, and she came back with a horrible disease. When soon after she returned from North India, she went on a 10-day trip. She became unwell on the return journey. The sense she had fever, vomiting, and then later found to have acute hepatitis, what we call the liver inflammation, where the liver enzymes go up and the patient develops jaundice. So it was a diagnosis of acute hepatitis because the patient is so unwell. She was referred to our hospital, and then we made a diagnosis that it is caused by hepatitis A. So what is the big deal about it? Hepatitis A is very common in India. India is endemic to hepatitis A, and majority improve without major illness, and it can be treated at home in many of them. But then some require hospitalization, some develop serious illness in the form of liver failure, even requiring transplant. So when this patient came into a hospital, she had jaundice, she had vomiting, she had some features of liver failure because her clotting was a problem, she had low blood pressure. So we sent blood cultures, and in 2 days, the blood culture grew bacteria, which was later identified as causing typhoid fever, that is salmonella. You would have heard an hour ago about this typhoid bacteria causing a lot of problem through Dr. Suresh's talk. So this patient had two illnesses. One is a viral disease caused by hepatitis A. She also had bacterial disease that is caused by the typhoid fever, that is salmonella, the blood. So that could be one other reason for her low blood pressure. She had multiple organ involvement, kidney, liver, and she was drowsy because the liver is not excreting the toxin and it's affecting the brain. Her blood pressure was low and she was, I should say, critically ill. And so why I'm bringing this? Because is it anything common because between this virus and bacteria? Yes. This can be both this infection, that is hepatitis A and typhoid, can be transmitted by contaminated water and food. And yes, both these are preventable. So food and sanitation, food hygiene is very, very important, especially in our country where sometimes the sanitation is still very poor in certain parts of the country. And if you're eating out, most of the time, you have to be very, very aware of what you eat, where you eat, and whether you have a good water source from where you drink and so on. Why? Because in our practice, we see repeated, it's very common, it is not rare in India. And any foreigner who's traveling to India, they take preventive vaccine for hepatitis A and typhoid because it is common. So if you are eating out a lot and you are not sure about what you eat from a hygienic place, you better get vaccinated because these both are vaccine preventable. Usually this virus, if it affects you, or the typhoid, it takes 2 to 4 weeks to recover, and there is you lose school hours or work hours. So it is a lot of impact. Even if it is not severe, you may have to be away from work. So it has impact on your revenue. And you have preventive options. Unlike Zika, for both these you have preventive options. So it's important that generally India should be very, very aware of food hygiene and water hygiene and about the vaccine availability. Generally, public should be aware of what are the vaccines available and whether they are eligible for and take appropriately. The second of the story is this patient was seriously ill and she would have survived. She wouldn't have survived if she had not undergone a liver transplant. Can you imagine a patient who is affected by a very common, simple disease that you would think of like hepatitis A or typhoid, and both occurring in the same patient, causing serious illness, ending up in liver transplant, costing 52 lakhs and 2 months of hospital stay and a slow recovery. And she was lucky enough to get a donor. So we cannot take any infectious disease lightly. It all depends on the volume of bacteria or virus you ingest and your host factors, whether you can fight it, and be aware of options of vaccines, and you should be aware of food and water hygiene, which is actually make this disease think that it can be very well prevented. Why did this patient have to undergo a liver transplant? Currently, she is doing well, but it has caused humongous for the family, and with all the support, she was able to recover. She was lucky to get a good donor, a relative, and this story ended well, but with a lot of lessons learned for all of us and for the general public. Thank you.
Thank you, Dr. Rajlakshmi. Indeed, a story which is quite tragic, both eminently preventable diseases, both fecal-oral transmission, exactly the same way that they are actually transmitted. And yes, you're quite right. Many often countries are able to invest in vaccinations for the population, but not really in clean water. And this actually has been a problem over the ages. So yes, anyone can be infected by superbugs. And so to wrap this session, we invite Dr. Sabine Kapasi. Dr. Sabine is a Global Strategy Lead from United Nations Disaster Assessment and Coordination. She's also an advisor to the National Health Authority. Dr. Sabine, we look forward to you talking to us.
Thank you so much, Dr. Abdul, for calling me for this. Thank you, Dr. Rupali, for the introduction. I am a gynecologist by education, but I have been working in disaster management with the UN now for 16 odd years. The reason I wanted to talk today was I wanted to actually shine some light on the fact that antibiotic resistance is not something that's easily diagnosed, even among the medical fraternity. We have had such huge advances in the field of tertiary care development, but still, some of the basic problems are something we don't easily throw light upon. And for that, I wanted to talk about two primary cases, something that happened very close and around me in India. This is during March, during the second COVID wave, post-March, around April. Happened to one of my house help's sister. She came to me with end-stage pregnancy convulsions around 7-month pregnancy. When I went and saw the patient at her home, she actually had a uterine catheter, an attempt to botch abortion. Now, this was done at as a non-registered clinic. I'm not quite sure how that happened, how they reached there. But there was a breach of the peritoneal ears. There was a breach of the uterine atmosphere in a big way. We had to rush, and this was a time when we actually had no heartbeat. There was no fetal heart rate present at that time. There was most probable mummification, which we weren't able to find out up until late. We rushed the patient at that time to one of the large government hospitals because it was most probably a medical legal case. And when they diagnosed her, she was running a fever of 103 with mummification. And this was a patient which was barely 15 years old. So now when this happened, along with the medical legal crisis, there was also a medical problem. No one really knew how to proceed on that because it might have been a minor case abortion attempt. So what happened after that was they took her for surgery with an MTP, of course. And after the surgery, after the mummification and the development was removed, the patient continued with high-grade fever for almost 18 days. Now, this was a reminder that this was again during COVID times when medical resources were very, very scarce. So what happened was that the patient had developed an obvious E. coli infection. They did try to treat her for 18 days with cephalosporin. She went into liver failure. No one was able to monitor her because this was an MTB case. And the 15-year-old girl died in the hospital. Now, there was not even an attempt. So all the understanding of what infection it was happened much later during the autopsy phase. This was a very heartbreaking thing that we saw during this entire chapter because we understand that it was a global crisis that we were undergoing. At that time, casualty was something that we all saw at a massive scale. But this was not just the lack of recognition of an infection. This was lack of understanding that there might be additional outcomes that might come out of it. There might be additional needs and changes. And this is one of the apex hospitals in the center of the country. So this was something that really shook me and took me to the research of looking at antibiotic resistance all over again. Second incidents that happened, which was again something that happened closer to me. And to be very honest, I blame myself to this also, because could have monitored it better, could have worked better on this, could have probably caught this earlier than it happened. Second, in the second case, it was case of delivery. This was someone employed at our hospital itself, and she went into delivery. She did not come back she wanted to go for delivery at her home village. We connected her to the right doctors, and she went for the delivery. The baby and the mother were healthy to begin with, but the patient post delivery had mild PPH. When the patients at that time, they treated her with they did not diagnose a PPNH right away. So what happened was the patient kept on bleeding mildly for almost 20 days before PPNH even testing was done. And when that happened, she was diagnosed with PPNG. We very soon brought her back to the hospital and treated her for it. Thankfully, the patient made it back, but she lost, as Dr. Rajalakshmi has said, almost 3 months of time with her baby, because continuously to that, she was showing symptoms. She was not able to go home. She was not able to breastfeed because of the stress as well, because she was on high-scale drugs. So I think that is one of the key things that we need to look at, diagnosing this early as much as possible. We need to reduce the cost of testing for a lot of these resistant problems. And that, I think, is one of the key factors that we need to apply, at least for the Indian diaspora.
Thank you, Dr. Sabeen, for those wonderful cases that you brought home to us. I think medicine is one field where we have so much of experience and emotion playing in every part of our lives that I feel this is one area where really artificial intelligence cannot take over. So the floor is open to questions, and I do see a couple of them there. And the first one I'm going to address to Dr. Suresh, if he's still online. Suresh, there's a question from Shireen Verghese. Why do you call Vidal an outdated test? Suresh, are you still online?
No, Suresh is not online.
Okay. In that case, if any of the other panelists want to answer. Okay,
yes,
I might. Yeah, please go ahead, Saurabh.
Ma'am, you are the best person to.
That's okay.
To comment on this.
Okay, so Vidal is considered an outdated test specifically because it has very low sensitivity and specificity. You can be wrong 30% of the time, and it's very rare for you to be right. It is usually in the acute illness, it's not that great, but as 1 week down the line, you can probably look at the rise in titers and guess retrospectively that that was possibly typhoid fever. So Vidal is not really, though it was described over 100 years ago. Unfortunately, we do not have another serology test to replace this. And this is something that is done, unfortunately, all over the country. And this is one of the most important reasons for antibiotic abuse, I think. So Vidal, definitely an outdated test. We should not diagnose typhoid based on this test. It's a very important message to convey to each and every patient that you see in the clinic. So I will ask the next question that I see is from Dr. Roop Chandak. Is carbapenem reported as per CLSI? We don't generally report, and I presume he was talking about carbapenem resistance for Salmonella typhi being reported. Yes, we don't usually report it. Any of the panelists would like to take this?
I'm sorry, I missed the question. Can you?
So I think the question was actually directed to Suresh. when he was talking about his typhoid patient. And I think he also described the ceftriaxone-resistant typhoid that we face in Pakistan. So Pakistan, you have ceftriaxone resistance, plus you also have MDR-S typhi, which is basically resistance to ampicillin, cotrimoxazole, and chloramphenicol. So Roop's question was, do we actually report carbapenem resistance? And if so, as per CLSI, why don't we usually report it?
We should not be reporting carbapenem for typhoid because it is a diagnostic supervision. In the recent time, if you look at most of the Salmonella is even susceptible to ampicillin and cotra. Actually, the susceptibility is returning back. We should be happy about that. We agree that some of the cases of typhoid, I find even non-salmonella typhoid, there is a resistance to ceftriaxone, more of ESBL, and even some carbapenem resistant. But salmonella typhi, the resistance to ceftriaxone is less. So most of the time we find it is sensitive, even it is sensitive to cotra and ampicillin sometimes, and those are the first line therapies till now. So we need not even think about carbapenem susceptibility, and we don't routinely test nor report. So if you find any of this resistant, probably you may consider further test.
Okay, thank you. So yes, I would actually agree with Raji with regard to carbapenem resistance. Yes, I think the question was based on the fact that all the ceftriaxone resistance typhoid in Pakistan was treated with meropenem. So does it work? Yes, of course it works. Should we actually give it? No, absolutely not, because we have azithromycin, a nice oral drug which works for typhoid. And like Raji absolutely said, ceftriaxone resistance is not reported simply because they follow the CLSI guidelines. Will those guidelines change for typhoid in the future? Probably. It'll take ages. If you remember, we reported the ciprofloxacin resistance in India in the early 2000s, but CLSI took 13 years to change their breakpoints. So probably it's going to be the same case. And yes, we do see a lot of late clinical defervescence in typhoid. So I think we are done actually, and I've got thank you so much to the wonderful panelists for those wonderful cases, elucidating to us how AMR is important, how we're running out of options, and how we need to be careful stewards of the options that we have left. So thank you very much, and we can wrap the session up.
Thank you.
Thank you, Priscilla. For the next fireside chat, Dr. Yamuna will be the coordinator. Yamuna, over to you.
A very good evening to everyone. This is the last fire chat session we will be having. The session will be chaired by Dr. Vidya Devarajan. She's a certified infectious disease consultant post FNB. She is also a certified infectious disease person from Royal College of Physicians. Currently, she is working as a consultant in the Department of Infectious Disease at Arela Hospital. Recently, she has been awarded as the Time Health Excellence Award in the year 2022. I'll be also introducing the panelist who will be talking today. Dr. Anup is a certified critical care medicine consultant who is currently working in Baby Memorial Hospital, Calicut, Kerala, who has recently received a Best Doctor Award from Kerala government. Our second speaker is Dr. Ankita Vaidya. She is currently working as a senior consultant infectious disease at Manipal Hospital, New Delhi. She is a certified infectious disease consultant. The third speaker is Dr. Bikram Das. He has completed his fellowship in infectious disease at Apollo Hospital, Chennai, currently working as a consultant. Our fourth speaker is Dr. Grace Mary. She is a PharmD person. She is also an American Board Certified Infectious Disease Pharmacist, currently working in the field of infectious disease clinical specialist and also heading the Department of Clinical Pharmacy at Believers Church Medical College Hospital, Kerala. The next speaker is Dr. Ravi Teja, who is currently pursuing his fellowship degree from Apollo Hospital, post-general medicine, and he will be doing the sixth session. The last session is by Dr. Vidya Krishnan. She is a certified infectious disease consultant from MGR University, and also she is MRCP-CH. She is also a certified pediatric infectious disease person from United Kingdom. So over to you, Dr. Vidya Devarajan, to chair the session for the last fire chat round.
Thank you, Dr. Emna. Thank you for the introduction. So, not going to hold on for long. I think we have a very interesting platter in front of us. So, we'll just go on to first speaker for the session. This is Dr. Vidya Krishna on Don't Breathe, a pneumococcal horror. I mean, like we all know, pneumococcus is definitely a major challenge in the developing countries, particularly when we have to deal with other communicable and non-communicable diseases. And none other than, I think, Dr. Vidya Krishna can tell us the impact that it has on the pediatric population. Yes, Dr. Krishna.
Good evening, all, and thank you to Dr. Ghafoor and the AMR Trust for organizing this and for giving us an opportunity to talk about the horrific stories that we face every day. So I'm going to talk about a case of a bad pneumonia in a child. So if you look at children, they're very prone to develop viral infections. Like a child in the school-going age group, say a 2 to 5 year old, on an average will have, say, at least one episode of a cough or a cold in a month. And of this, sometimes some of them can turn into a pneumonia, right? So given that fact, it means that any child who's developing is going to go through at least one episode of pneumonia, has a good chance of going through that. And then if that becomes a very serious or a deadly disease with no treatment options, it's a real nightmare. So this case, I'll just directly go into the case and then I keep talking about the points that I want to stress on. So this was a young girl. She was like just about 3 to 3.5 year old. So born after a significant delay. So thought to be like what we call as a precious child, no? Like, so parents were really very keen about her every aspect of the child, like any parent is. But then they were very sure that they gave her all the vaccines. They took care of her very well, even if she had a minor illness. Immediately they took her to the doctor, and then the only thing is they'd already lost one kid to some infection. We don't know what it is. Sometime in the newborn period, the child had developed some infection, and the child could not be treated properly, and then the child got lost. So they had a little bit of apprehension, and they were always worried about like whether something could be missed. So I think every time they went to a doctor, they made sure that the child got, even if it was just a viral infection, a cough or a cold, just like that, they wanted to make sure that the child did get some antibiotic so that the child does not become serious or doesn't catch a severe infection. So by this time, with the child, like say is 3.5 years, the child has had multiple courses of antibiotics for what we would say is just a common cough or cold. And again, this child ended up with what looked like a fever and cough. Again, this time presented with what looked like a fever and a cough. Started off like that. Started on antibiotics on day 1. And then by 3 or 4 days, the child did not improve, continued to worsening cough. And then they decided that they want to get the child admitted to a hospital. And again, this time they thought that they would choose a doctor who they had some reliability on. So they chose one of their own relatives who was an adult physician. And then this child gets admitted in a hospital outside and then gets started on treatment. So here again, so normally the common causes that we think of in childhood pneumonia is, as we say, pneumococcus is the commonest bug. And pneumococcus is supposed to be a very sensitive bug as far as we know. Like it's usually the drugs that we use like ceftriaxone, amoxicillin, all those drugs should work. Like there's no reason why we should suspect that a child who comes from the community with a bad pneumonia actually has a resistant pneumococcus. So this child gets admitted and then as per protocol gets started on ceftriaxone. But ceftriaxone, if you look into it, there are so many brands in the market. And then now we have a lot of combinations like ceftriaxone with sulbactam, which are not rational. There's no reason to add ceftriaxone and a sulbactam and market it. But then it's there available in the market and then it gets administered because the way it is, like the way it's prescribed or the way it's transcribed. So then what happens is actually in children, the pediatric dosing is based on the milligram per kg. So when you're using plain ceftriaxone, suppose you're aiming to give an 80 mg per kg, and then you give a combination of ceftriaxone and sulbactam and still stick to the 80 mg per kg, then the amount of drug that the child actually receives is much less, because the combination has two components, both the ceftriaxone and the sulbactam, and then the dose of the ceftriaxone actually comes down. So this is what unfortunately happened with this child. Gets admitted, gets started on what looks like ceftriaxone, but gets a very minuscule dose of ceftriaxone for the next four days in the hospital, and child is not improving. So then the parents are worried as to why the child is not improving. And then this goes on for some time. And then actually by 4-5 days, the child is very bad. Now the child has developed a very bad respiratory distress, needs to be on oxygen, and then goes into shock. And then it's haywire all around now. So finally, at this point, the treating physician decides that it's no more my area. Like, this is a child, so better I refer to a pediatric hospital. And that's how this child landed up with us. So child came in a very bad shape, came in with very bad pneumonia, very bad respiratory distress, requiring oxygen, had to be immediately intubated, put on the ventilator, and then required multiple drugs to keep the blood pressure support up. And this went on for some time. And then immediately what happened is the lung didn't seem to improve. So when we did an X-ray and all that, we found that both the lungs were very badly infected. And also the infection had spread into the pleura. Pleura is the covering which is around the lung. So this infection had actually spilled over into the pleura and had a lot of pus in the pleural cavity. So which meant now this child we had to do a procedure. So we had to put in a tube and drain out all the pus from the lung cavity, from the pleural space. And even with that, this child did not improve. So this child went on to what we call as a lung support. So sometimes, like how we do a cardiac bypass, this child's lung was not working. So we had to put this child on what we call as an ECMO. ECMO is like you bypass the lung and then you just give the lung some rest, and the machine takes care of all the oxygenation and all the lung functions. So this bad. And so this was going on for some time. So this child had to be on this ECMO support for almost close to 3 weeks. So just to put it into perspective, a simple day in the ICU on an ECMO can averagely cost anywhere like between 2 to 2.5 lakhs just to be on the support. I'm not talking about the antibiotics and other things that the procedures that we do, the surgical interventions that are required, all those things are added costs. So only this, and imagine having a child on ECMO support for 3 weeks. So it was I can't talk to you about the financial burden. It's a huge financial burden for a average Indian family. So this is what happened. And then finally, we actually grew the pneumococcus. So the pneumococcus, it was proven to be a pneumococcal pneumonia. It grew both in the blood and in the pus. And to our surprise, it was resistant to almost all the drugs. It's like this, normally we have very good data from our own CMC fellow from where Dr. Priscilla is. So which says that pneumonia, the pneumococcus which causes pneumonia is supposed to be sensitive to ceftriaxone, sensitive almost 98% of the times. But in this child, unfortunately, probably because of recurrent antibiotic exposure or probably because the inadequate ceftriaxone dosing that she got outside, we had very few drugs to treat. And we couldn't use certain drugs like what we would normally use, like vancomycin and all that, because she was on ECMO and the circuit would just pull up all the antibiotics and then we could never achieve blood levels. So we had only a couple of drugs. One is linezolid, another one is levofloxacin. And both these drugs are extremely toxic, especially when talking about giving it long term and giving it in children. So like normally when we treat a child with a bad pneumonia and an empyema, we would treat for at least 6 weeks. So these two drugs have a lot of toxicities and it's not very good to be used in children. So what I wanted to drive home by this thing is two things. One thing is definitely children are not little adults. And they cannot be treated the same way like how you would treat an adult. The antibiotics that you would use, the toxicities that you need to monitor, the long-term effects of even a simple infection or these drugs are totally different in children. So somewhere it's very important that children get treated by people who know how to treat children, and then they get the right drugs and the right monitoring that they need. The second thing is a little bit of healthcare seeking behavior that we have. Like normally, as I said, for a child, it's very common to develop a viral infection, whereas for an adult, it might not be so. For a child, if it's an infection, it's usually viral. And many times, it can go on, the fever can go on for up to 3 to 5 days, or sometimes of late, we even see up to 7 days. But then there's so immense pressure and so much expectation that this child should get better immediately. The severity of illness is not graded by the persistence of fever or something like, or the persistence of cough. The severity is usually by how well the child is able to breathe, how well the child is the child looking alert, or child becoming dull, or whether the child needs oxygen. So somewhere we mistake that a high fever means it's a very severe illness, and we think that only if we give antibiotics, this child will come out. Most of the times, it's just patient care, supportive care and masterly inactivity. Don't do anything. Just wait for 3 to 5 days. Give some normal paracetamol or cold medications or something that you would want to give. And then just let the pediatrician do the job. Let them just give antibiotics if they think it's definitely required that this child needs an antibiotic. Somehow that is lost in translation. It's lost in actual practice most of the times, because there is so much anxiety that this child has to get better immediately. So these two things, I think, pneumococcus is again a vaccine preventable disease. Only now we have recently put it into the national immunization schedule. This child did get all the vaccines, but still had a breakthrough through that. Again, a lot of things to look into, like cold storage and other things. But I think the point to drive home again and again is just be patient with viral infections. Don't expect them to be relieved with antibiotics, and that shouldn't lead to something, a simple pneumococcus, which is supposed to be sensitive to all the drugs. Now this child being exposed to multiple antibiotics for what looks like simple infection, and then lands up with a deadly disease. Thank you.
Thank you, Dr. Vidya. I think we've had like a very good take homes from this. Children are not small adults. Really look at the doses of antibiotics that you give, and the response to fever is not an antibiotic, which, I think you've really conveyed it very well. And it's really sad to listen to these, stories though, but I think they are eye openers. Just a couple of questions for you, Dr. Vidya. How big you think? In adults, we all know that basically AMR is a big challenge. So how big is the problem of antibiotic resistance in children? So what's the state of AMR in children? I'm sure you'll be handling a lot of NICU babies and PICU. So what is the impact of AMR?
See, here again, it's very important to say that we have very good hospital data. Like we look at, like, say, an NICU or say the oncology setting, where we almost see kids, like children who come in with cancers, children who come in for bone marrow transplants. Here, we have to use a lot of antibiotics for various reasons, because children newborns who are as young as, let's say, weight 500 grams or 600 grams are surviving today. And they're surviving today because they go through a lot of interventions, and any intervention adds to a risk of infection. And luckily, we have some antibiotics which work, and which means that we expose them to antibiotics. And by the time a newborn comes out of an NICU, is exposed to a whole lot of antibiotics for these reasons. So the newborn and the transplant settings, definitely a lot of antibiotics are required, and we also see a lot of resistance. This one thing I want to stress, in the community, what actually happens, how much antibiotic does each child receive? What is actually the prevalence of drug resistance in the community? We have some data from ICMR, but I sometimes feel that children are often neglected in most of the research and most of the surveys and most of these data collection that we do. Most of these data comes from an adult centers, multiple hospitals. Pediatric targeted data is hard to come by. So that is again something to be stressed on. Pediatric oriented research, pediatric oriented surveys.
Thank you so much about that. And what do you have like a take home for parents and public? How can they prevent pneumococcal infection? And what about some kind of tip for them when it comes to antibiotics in children? Because I'm sure you've come across this in your OP about stressing for antibiotics. In the outpatient, when a child comes to you with fever, they just want antibiotics.
So the first question first, like the first one was about how to prevent, right? So first thing is basic hygiene measures. No, this is something which is worth emphasizing again and again. So if you're sick, stay away. Like, you don't go to crowded places, especially when you have an ongoing viral season going on, like say an influenza, or right now even the winter months, we see so many viral infections in children. So better to, I know it's a little restrictive to say this, but probably that's the best way. If you don't want to catch a cold or cold, don't go to crowded places. And like masking, I think had helped a lot during COVID pandemic. Unfortunately, now it's not anymore in a regulation to use mask, but definitely during an ongoing outbreak, or when you feel that the viral infections are higher, masking, hand hygiene, and then definitely sticking to the routine childhood vaccines, giving the pneumococcal vaccine, giving the annual flu shot, especially in under 5-year-olds. All these things are very, very important. And now we also see a lot of typhoid in children. I think it got to do with a lot of travel outside and eating outside. So something that parents need to be very aware of. Be very careful where you eat from and what you eat. So food hygiene, water hygiene, vaccines, these are very important when you want to prevent infections in children. I'll move fast to the second question. So this is what I mean. I think it's very important that you, when we seek healthcare, it's very, like, if a doctor, it's on both sides. The doctor also has to take the onus and explain to the parent that this is just a viral illness, and we will wait and watch. We'll give it some time, see how the child does by day 3 or day 5. Child doesn't improve, then we will decide to investigate and decide on starting antibiotics. Versus crowded OP, no time, and just no time for the parents and the doctors to speak, just prescribing antibiotics. So reflex antibiotic prescribing is something which should not happen both from the doctor's end, as well as parents also should not feel that antibiotic is an end all to all solutions. So I think it's something which should be worked on both sides.
Sure. Thank you, Dr. Krishna. I think we have the next speaker here for us to tell us some stories about the black fungus. I think that has dreaded a lot of us during the COVID times as well. So we have Dr. Ravi Teja here. Dr. Ravi, can we listen to some of the horror stories about the fungus?
Thank you, ma'am. Are you able to hear, ma'am?
Yes, doctor, if you could increase the volume a little more.
Are you able to hear, ma'am? Now it is okay, ma'am?
Yes, doctor. Yes, doctor.
Good evening, everyone. At first, I thank Dr. Kapoor, sir, for giving me this opportunity. A black fungus horror story. The title aptly suits what our patient and his family experienced, and we treating doctors also experienced similar horror in managing the patient. Our patient was a 50-year-old man with diabetes and chronic liver disease. He was admitted to the hospital in May 2021 during the second wave of COVID with severe COVID, and he required oxygen support via non-invasive ventilator support, and he was treated with steroids and remdesivir. He was in hospital for about 1 month, and of all the trauma he had during the hospitalization and all the anxiety among his family, he finally recovered from that severe illness and was sent home. 2 days after the discharge from the hospital, the patient noticed blood in his urine along with decreased urine production, and he started to have breathlessness, which was gradually progressive. So he had come to the emergency, and on evaluation, the patient was found to be having acute renal failure along with severe metabolic acidosis. Metabolic acidosis means the renal shutdown has happened and the body had accumulated all the wastes, and we admitted him and we started him on dialysis. For evaluation of his renal failure, we have done a renal biopsy. We showed necrotic kidney tissue and fungal elements in the biopsy, which was suggestive of the so-called black fungus, say mucormycosis. And subsequently, we have the urine culture we have done, which also grew the same fungus. And we immediately initiated him on costly antifungal injection called amphotericin B, which is a drug of choice for this fungus. Later, we did the CT scan of the abdomen. We showed aneurysmal dilatation of the blood vessels, which supply the kidney, along with complete obstruction of the blood supply to both the kidneys. We thought it is likely due to a severe, aggressive, bad fungal infection. Despite starting on him on appropriate treatment, his health condition rapidly deteriorated, and we had to take the option of removing both his kidneys to save his life. So we have performed laparoscopic surgery and we have removed both his kidneys and we have continued the antifungal injection. So after the surgery, his health has gradually improved and he was doing fine. But again, on 45th day of treatment with this costly antibiotic for about 45 days, one day he started to have breathlessness again, along with syncope and arrhythmias. And we have rushed him to ICU and we have done echocardiogram. We showed reduced ejection fraction compared to his baseline cardiac function. And after discussion with other departments, cardiology, nephrology, and after ruling all other causes of heart failure, we concluded that his heart failure is due to the cumulative accumulation of the antifungal injection, amphotericin B, and is likely amphotericin B related cardiomyopathy. So we had no option but to stop the antifungal injection as he was having recurrent arrhythmias and life-threatening hemodynamic instability due to heart failure. And we had no option other than other antifungal medicine called posaconazole, but he was already having underlying chronic liver disease. So after explaining all the risks to the patient, family, we had given him the option of giving the posaconazole. So we have given him started treatment on posaconazole, but within few days the patient liver function deteriorated, and in spite of making best efforts, we lost our patient to a horrible black fungus for which we had no option to treat. This was the case we had last year, and it was very difficult to manage, and we could not save the patient because we had no options.
I think that was really an interesting case, and that's the case with the and some disturbance. Yeah. So we'll come back to you again, Dr. Ravi Teja. We will move on with the session and a few more stories from the rest of them. We have our next speaker, Dr. Anu. Dr. Anu, yeah. So we have Dr. Anu here about The Dark Night Rises Again, a Nipah story.
Good evening, Dr. Vidya, and good evening, others. So first of all, I would like to thank AMR Trust and Dr. Gafur for giving me this opportunity. So this story, I think, will be familiar to most of you. This happened in 2018, actually in May 18th. So on an early morning on 2018, in Calicut Baby Memorial Hospital, I'm working as a chief of critical care medicine in that hospital in Calicut. So we received a 26-year-old man with a history of fever and altered sensorium of 3 days duration. So he started having a fever, then he became confused and was having a breathing difficulty. He was initially admitted in a local hospital in Calicut district and later shifted on early morning at around 2 a.m. To our hospital. So on arrival to the emergency department, he was confused, he was having fever, and again, he was having breathing difficulty also. So usually when a patient comes with fever and altered sensorium, we think about the brain infection, the so-called encephalitis. And usually we take a CT scan of head. Then we proceed with the cerebrospinal fluid analysis. So whatever fluid is there in the brain, the same fluid we can aspirate from the spinal cord as well. So usually that is how we diagnose a brain infection. So this patient was also taken for a CT, then later shifted to the ICU. So in the ICU, he was extremely confused and was agitated. And the CT head at that time showed there is a severe brain swelling, or we call it as brain edema. So when the patient is having a brain edema and when he's extremely delirious, it may not be possible for us to proceed with the CSF examination. So we have electively intubated him and connected to ventilator. So initially, after intubation and ventilation, his blood pressures were too high. His heart rates were high. We call it as a sympathetic surge response. He had tachycardia and high BP. So usually this is not observed in an encephalitis patients. Any patients coming with sepsis, encephalitis, etc. When we sedate them and when we tube them and put them on ventilator, usually the sympathetic surge or the sympathetic drive will be blocked, and again patient will be usually having a drop in BP, etc. But this patient was having a persistently high BP and high heart rate. So he continued to be in that situation, and his lungs were also bad. We call it as something like a ARDS. So he had the X-ray, he had infiltrates, and in the ventilator also he was requiring high oxygen support and other ventilatory requirement, or he had severe ARDS. So in the morning, like as I've told initially, he had a severe hypertension, again increased heart rate, etc. But by the next day morning, like when we came for the rounds, he started dropping his blood pressure, and again the heart rates were also continued to be on the higher side. And the echo, when we repeated, it was showing heart dysfunction. Heart was not pumping properly. So probably a patient with an infection, when the heart function is deteriorating, we call it something like a myocarditis. So he was developing features of myocarditis also. So what we did next was, with these supports, like his lung function has slightly improved, or in other sense, the ventilator requirement has come down. So he was shifted, and we got an MRI brain done. And MRI at that point of time looked normal. The brain edema has slightly subsided. Then we proceeded with the CSF analysis. The cerebrospinal fluid was aspirated and it was analyzed. And along with that, the routine investigations. Look, initially he had a slight thrombocytopenia. Platelet count were on the lower side. His hemoglobin were also slightly on the higher side. So whenever a patient is having thrombocytopenia and a hemo concentration, we usually think in terms of dengue fever also. So the dengue, NS1, PCR, all those things were also sent. And again, other routine workups were also sent. And after aspirating the CSF, it was sent for all routine tests. And the initial screening was showing the normal CSF protein, sugar, the normal count, etc. So by this time, again, he started deteriorating. His BP started falling. We had to give more vasopressor supports for him, and his LV function was also deteriorating. So at that point, we again started thinking about any other causes. I've already told the usual initial sympathetic surge and early myocarditis. These features are usually uncommon in an encephalitis patient. So at that point, again, we called the relatives and I took a detailed history. So then we came to know that his brother died of the similar symptoms in a nearby medical college almost 2 weeks back. Now this person is also having developing the similar symptoms. So that again made our team to think about any infectious etiology where the index case may be spreading the disease to others. So at that point, we again had a detailed discussion with the relatives, and we told that there is a possibility that the initial person may be infecting more people. So like, is there any persons in the family or the neighborhood having similar symptoms? So initially they denied, like all the family members are okay. Even the neighborhood also, they have not observed any abnormal disease like that. But later on, they admitted that these patients, his brother's fiancée, who attended the funeral function of his brother, and his aunt, and his father, all are having fever. So we requested the family to bring these members also to our hospital. So usually when a patient is having only mild fever and ours being a private hospital, getting these patients admitted was also difficult, but somehow we could convince them, and these 3 persons also got admitted. But these 3 were initially admitted in the ward, and during the initial examination, I personally went and examined all these patients. So one patient had few pustules in the urine and some dysuria or irritative voiding symptoms. The other person had some cellulitic features in the leg. Other than that, they were all looking normal. That's why we, just for observation, we admitted all these 3 patients in the ward. But these patients also became confused and was shifted to the ICU by the same day evening. And one abnormal features observed in that was the aunt who was admitted. She was conscious, obeying, but she was showing some abnormal movement in the legs. So that was actually like a segmental myoclonus. So initially we thought it is something like a somatization disorder, something like that, where she has become panic as these all patients are getting admitted. But she was not having any other abnormal symptoms. But in the ICU, again, she became more delirious. We had to intubate those 2 patients also. So by next day morning, we had the 3 patients in the ICU. The brother's fiancé was almost normal. He was still in the ward. So by the next day morning, we had 3 patients in the ICU with encephalitis, and one index case who died 2 weeks before. And these all patients were having abnormal features, like they all had the sympathetic surge, tachycardia, hypertension. They had segmental myoclonus. One patient had ptosis. Then the segmental sweating was also observed. So these were, and the myocarditis was also seen in all these 3 patients. And when we took a detailed history, again, they actually were their house was near a forest, it was an eco-friendly area there. There is a tourist spot, a forest there. And there were so many bats in that area, and they have consumed the fruits, that's the mangoes from the tree. So that was the only history we got. So by this time, all the investigations from our side were negative. And we had a confusion that this is something like an unusual fever. So at that same time, we contacted Dr. Arun Kumar in Manipal Virology in Manipal. So we have discussed the case in detail with him, the clinical features, everything. So he has also was an opinion that it can be something like some viral encephalitis. So he requested us to collect CSF, urine, blood, and the secretions from the throat swab for the analysis. So all these samples we have to send to Manipal. So this again, there is almost 400 kilometers from Calicut to Manipal. Sending the sample on such a short period was also a bit difficult. But somehow we convinced the relatives, and they were ready to travel with this sample on the same day night itself. And by the next day morning, they got the sample. And unfortunately, by this time, the first patient who got admitted, he expired because of this severe myocarditis and circulatory insufficiency. And later only, the next day evening only, we got a report from Dr. Arun saying that he has identified an abnormal virus. And by this time, we have also had a bedside discussion with our general medicine neurology team. And we have again analyzed all these symptoms, which I've already mentioned, and again, the history of the contact with the bats. So putting all these together, the clustering of cases, these abnormal features like sympathetic oversurge, the segmental myoclonus, the ptosis, then the contact with the bats, we had a clinical suspicion that it can be a Nipah. And that was also communicated to the virology team and specifically asked for getting that test done. And later, the result came as it is Nipah, the PCR positive. And one thing the found at that point was the CSF, the PCR was negative. It was detected from the throat swab alone. All other samples were negative. By this time, like again, one nurse you all might have read, like who was carrying the first index patient got sick. She had mainly ARDS only without encephalitis. She also got intubated in Calicut Medical College and she died. So, and again, by that time, the government has also acted very well. They formed the team in the Calicut city itself. And we started observing all the contacts, and all the contacts of these patients were identified. And some of these contacts also developed symptoms. So altogether, we had 20 cases at that time. And out of 20, all 18 patients died, and only 2 survived who were only having mild encephalitis.
And as far as Dr. Nanup, like, can we sum up?
Yeah, I'm just concluding.
So that you can take a lot of questions also in the end.
I'm just concluding. So at that time, we were not having much treatment options. Only ribavirin, a few studies were there. So we have given ribavirin. And the monoclonal antibody was imported from the Queensland, Australia. But by that time, we lost all the patients. So even though we diagnosed a very rare disease, and again, had to we were able to control the outbreak, but again there were no treatment option and the mortality was too high. Later again in 2019 and 21 we had at Kerala like 1 case each, which there was no spread from that case. So that is all about this Nipah story. Thank you.
Very, very interesting story, and it's an eye opener for us. I think there'll be a lot of questions towards the end. We'll come back to you soon. We have our next speaker, Dr. Grace and John. So far we've been talking about bugs. Now I think it's time to talk about how drugs bug us. So over to you, Dr. Grace.
Thank you, Dr. Vidya. I take this opportunity to thank Dr. Abdul Ghafoor and the AMR Declaration Trust for giving me this platform to address, like ma'am said, the drug-related issues that we face in our common practices. So the topic is no strings attached, a need for drugs without interactions. So here I would like to present a case that is a bit of a complex one, but I will try and make it as easy as possible for you. So we have a 51-year-old retired Army Jawan who lives with his wife and 2 children, 2 daughters actually, in Bihar. And he was experiencing symptoms of fever and cough for over more than 5 months period. And initially he went to a local hospital for treatment, and because of the fever, like in everywhere, they used to get, the 3 to 4 courses of antibiotics. He got antibiotics for his fever, but it was not subsiding, and he never found relief with the antibiotics alone. So during this course of illness, he started to lose weight profoundly and was becoming thinner by day. He looked emaciated and had no energy to do his daily activities. His local doctor actually advised him to go to a higher center because they felt that they couldn't handle this case, whatever was going on. So he advised to go to a higher center. But he had a history of TB like 2 decades before, in 1992 to be exact. And he was treated, and recently his daughter had, the tuberculosis infection in her abdomen. And they know how difficult it is to treat such infections and the terror of that going somewhere. And, the family was all worried, and the father, especially thinking of his 2 daughters, the financial constraints, going to a new place, they got worried. So he decided to wait it out and see what will happen. So again, what happened was that because he was profoundly losing his weight and because he was becoming more and more tired, he had to approach the local hospital again. And this time they found that he was severely anemic. That means his blood levels were too low and they had to transfuse blood for this patient. So over a period of 3 months, he received 3 pints of blood, and they finally decided that they are going to a higher center because this cannot go on. So he went to this reputed tertiary care hospital, and the doctors had to evaluate him thoroughly. And like I said before, he had the history of tuberculosis, the chest infection, the pulmonary tuberculosis in 1992. And he gives a history that he took 6 months of therapy and he was declared to be cured of the infection. But he denies any other medical condition that he's having. And because it's a long-lasting fever with profound weight loss, with fever and cough, a detailed evaluation was performed on this patient. So the initial picture, what the blood test came back was that his hemoglobin was on the lower side, like we expected, and platelets were also on the lower side. And he was found to have uncontrolled diabetes and like a borderline, the diabetes has affected his kidney, and therefore, a borderline kidney disease was also seen in this patient. His X-ray was taken and his chest showed various patches or haziness, which was abnormal for a patient. And therefore, they had to see what's exactly going on. And because of the symptoms of cough with sputum production and with these X-ray findings, they had to go for an extensive testing. They did a bronchoscopy where a tube is inserted into your lung and see, what is the problem. You get the samples. You get even if you want to take some biopsy, you take it. So all these samples were taken, and along with that, because he had low blood counts for platelets and the hemoglobin, a bone marrow biopsy along with the culture was also done. And the first major shock of his life he got when he tested positive for HIV, which is the human immunodeficiency virus infection, and the emotional trauma the family had to experience was just like we are all saying, it's horrific. And they couldn't just get a hold of the thought of the social stigma that exists towards this disease. But despite all odds, the family decided to fight back and ensure his recovery, putting the past behind them. So during the next few days, even though he was started on some initial treatment regimens, he was not improving. So during the course of the next few days, his pending reports came. And the doctor told him that the HIV or the human immunodeficiency virus was not just the only infection that he's having. And because this virus has the potential to cause the actual immunity to come down, he has contracted 2 other major infections as well. So he had been diagnosed to have one bacterial infection, exactly a mycobacterial infection called, the disseminated TB. The TB that he earlier had, the tuberculosis that he earlier had in his lung has been disseminated now. And also he has now a new fungal infection, which with the culture and other reports said that it is disseminated histoplasmosis. And both being called disseminated means that it has been spread out to the other parts also. This histoplasma was found in his urine and in his bone marrow. So the doctor counseled him regarding how difficult it is going to be to treat both these diseases, and both these diseases will require a longer therapy, a longer duration of therapy. Now, the difficulty came because right now he is having a triad of 3 different infections going on: a viral infection, that is the HIV, the bacterial infection, that is the disseminated tuberculosis, and a fungal infection, which is a disseminated histoplasmosis. So having this mix of 3, even the doctors struggled to come up with the right mix of drugs. And that's where the drugs come into play with regards to the no strings such as, because every drug has its own crux to it. So his TB drug, the usual regimen that we give for a TB drug, a drug called rifampicin, it is a drug that can cause, differences, or it can interact with other drugs by either eliminating it out of the body, by increasing the metabolism of the other drug. And this drug, this rifampicin, if given with the other drugs, example, the one drug that you need to give for a patient with histoplasmosis would be itraconazole, an antifungal agent, an itraconazole or a voriconazole. But these drugs, if given with rifampicin, will cause therapeutic failure, because rifampicin will increase the deactivation or metabolism of the other 2 antifungal drugs, and therefore there will be lower levels of the antifungal drugs in your body, thereby contributing to therapeutic failure. Similarly, if you give this rifampicin with the HIV drug, which is the dolutegravir that you usually give now, again, the same thing will happen. The rifampicin will decrease the amount of dolutegravir in your body, and therefore it can cause to therapeutic failure if not addressed the right way. Now, because he is having kidney disease, going for other options also makes it a bit more. Exploration of other possibilities or other choices also makes it a bit difficult, and it can lead to various toxic effects of the other drugs, thereby leaving us with little to no options for treating his medical condition. To the medical fraternity that is listening to this talk, I will summarize the case. That is, it is a 51-year-old male with 5 months of history of fever with cough with expectoration, with profound weight loss and anemia, previous history of pulmonary TB, which was treated and said to be cured. His daughter had abdominal TB 1 year back and now is well. No non-comorbidities. The initial examination revealed pallor, no palpable lymph nodes or jaundice, JVP is not elevated, scattered crepitations in bilateral lung on auscultation, no organomegaly, no focal neurological deficits. The baseline test shows anemia, thrombocytopenia, and a 3 times elevation of the alkaline phosphatase, a creatinine of around 1.5 milligram per deciliter. HIV1 is positive, and with the CD4 cells of 204. Expert of the sputum and bowel was also sent. Cryptococcus antigen was negative. Bone marrow culture shows ill-defined granulomas. Serum galactomannan was 4. He was initially started on voriconazole, but he was still persisting fever. That's when the other reports came in. The urine histoplasma antigen was positive. Bone marrow culture was positive for histoplasma. 1 week later, the transbronchial lung biopsy came, which grew mycobacterial tuberculosis, thereby leaving us with a final diagnosis of a patient living with HIV, 1 stage, WHO stage 4, CD4 of 204 cells, on now started on antiretroviral therapy, disseminated histoplasmosis, and disseminated tuberculosis. Now,
thank you so much. I mean, if you could just sum up. So basically, it looked like a multiple OI, immunosuppressed host with a lot of challenges in drugs, in therapy with interactions, toxicities, etc. I mean, that was very, very nice. Thank you so much for the very interesting case. If we can move on to the next, horror story, or from Dr. Vikram Das, we have a Cupid superbug from the massage parlor. I mean, it's not a horror story, probably it's an interesting story that Dr. Vikram has to tell us. Thank you so much.
Am I audible, ma'am?
Yes, Doctor.
Okay. Good afternoon, everybody, and thank you, madam, and thank you, AMR Declaration Trust and Dr. Abdul Ghafoor sir for this kind of opportunity. So I'll narrate a story of a 19-year-old college student from Kolkata. He came to us with his elder brother with a complaint of persistent urethral discharge, that is whitish discharge from urethra, and pain during passing urine for last 3 weeks. On history taking, we found that he visited a massage parlor in Thailand in his recent trip to Thailand with his friends, and also he revealed that he had unprotected sexual intercourse with an unknown lady there. And 5 days after all this, he started having his symptoms. But he was very scared of revealing all this, and on his return to India, he started taking medicines on his own and with the advice of his peer group without any advice from any doctor, and took a lot of antibiotics in the form of amoxicillin, clavulanic acid, cefixime, doxycycline, ciprofloxacin, but his symptom did not relieve. And he was very much worried, and he was very depressed. And actually, he was confined to his room and was not taking food properly when his elder brother noticed all this. And then he was counseled well and was brought to us. When we examined him, he was stable, and there was no fever. On general examination, there was nothing significant. And on genital examination, actually, there is a urethral discharge. White is urethral discharge, but there was no penile ulcer, or there was no inguinal lymphadenopathy, lumps in the inguinal area, or any scrotal swelling. So with this case of persistent urethral discharge syndrome, what are the possibilities? Probably it is a sexually transmitted disease. So is it a partially or inadequately treated non-gonococcal or gonococcal urethritis? Basically, gonococcal or non-gonococcal urethritis is nothing but a sexually transmitted urethral infection. A large part of it is caused by gonococcus, that is Neisseria gonorrhoeae. We call it gonococcal urethritis, and another part is caused by organisms other than Neisseria gonorrhoeae, that is chlamydia, mycoplasma, etc. So we classify them as non-gonococcal urethritis. So is it an inadequately treated gonococcal, non-gonococcal urethritis, or it is a re-exposure? Because sometimes patient will not tell you about the re-exposure history, and we confuse it with a persistent discharge syndrome. Or it is a co-infection, because sometimes 2-3 organisms will enter into the same route and they will cause the same disease, and they are very difficult to treat. Or is it something caused by some resistant organism? Because in this era of increasing drug resistance and emerging resistance to ceftriaxone for gonococcus, and the patient acquires this in Thailand, we must keep in mind that there is possibility of drug resistant gonococcus for this kind of patients. So with all this in mind, we started evaluating the patient, and we sent the urethral swab for microscopic gram stain culture sensitivity. And we asked him to collect the morning first catch urine sample and to send it for gram stain culture sensitivity microscopy, as well as nucleic acid amplification test. So nucleic acid amplification test is basically a molecular test, that is a point of care test. We get the results same day. And what we do in this test, we amplify a specific target region of a genetic material of that organism. And we detect it after multiplying, and we can detect it at a very low load. So the sensitivity is much higher than the culture result itself, and we can identify it much faster. But the problem is we cannot tell about the sensitivity reports. So we have to wait for the sensitivity. And the problem with gonococcus is that the culture also is not always having a very good yield because of a lot of reasons, and delay in the inoculation. All these things are there. Anyway, the next day we got the report of microscopy. There was a gram-negative intercellular diplococci, which is suggestive of Neisseria gonorrhoeae, and also in NAT we got the Neisseria gonorrhoeae identification. So we stopped all the antibiotics, and at this point of time, his elder brother was very much keen to start some antibiotic, because he was already suffering for last 2 weeks, and it was not resolving. But actually we are at loss. We don't know what antibiotic to give, because he was already exposed to azithromycin, he was already exposed to ceftriaxone, and there was possibility of even getting a ceftriaxone. He was already exposed to cephalosporin, that is oral cefixime. So there was a possibility of getting a ceftriaxone resistant gonococcus as well. But pending the culture report, we started him on injection ceftriaxone at a bit higher dose. In developing countries like us, there is a syndromic approach for treating this gonococcal or urethral discharge syndrome. Here the treatment actually is injection ceftriaxone 250 milligram, or we give oral cephalosporin like cefixime and azithromycin, single doses. But for this patient, we could not rely on this syndromic approach, and there was possibility of ceftriaxone resistance. So we followed the UK guideline and gave him 1 gram of ceftriaxone, and we waited for the culture report. But we were never sure whether he's going to respond to this or not. And on day 5, we were lucky enough to get a culture report, and there was a growth of Neisseria gonorrhoeae. And definitely the culture report was very astonishing. There was a high level drug resistant to azithromycin also. It was definitely resistant to penicillin ciprofloxacin tetracycline, but it had added resistance to azithromycin, and that was high level. And it was resistant to cefixime, oral cephalosporin. But luckily we got an isolate which was sensitive to ceftriaxone. And the patient also responded clinically in 5 days. But he informed over telephone, but he did not come for a repeat test, that is called the test of cure, to definitely tell whether the test cured or not. But he did not show up to OPD after this. But the concern remains, because actually if we get a ceftriaxone resistant drug resistant gonorrhea, that is called the extended drug resistant gonorrhea, no drug combination actually has been well studied to combat this infection. And with this concern of having no options in future probably for a ceftriaxone resistant gonococcus, and also there is scarcity of lab for proper diagnosis of this infection and the resistance. I think I should conclude here the story. Thank you, ma'am.
Thank you, Dr. Vikram. I mean, I think that really stresses the importance of, some easily treatable infections like gonorrhea with less toxic drugs. Now we are looking at resistance, not just in Klebsiella, but also in gonorrhea. That's actually quite scary. Also tells us importance of rapid diagnostic tests as well. Thank you. We have Dr. Ankita Vaidya now to talk to us. I think we've spoken about a lot of bacteria. Now let's listen to scary stories about what viruses can do to us. Over to you, Dr. Ankita.
Thank you. Thank you, Dr. Vidya. So at the outset, I'd like to thank Dr. Ghafoor and the AMR Trust for giving me this opportunity to talk about this. So I stay in Delhi practicing as an ID physician in Delhi. And we know in Delhi, especially, the dengue is so much endemic, and we are seeing so many cases of dengue every year. And this again is always a challenge when we talk about dengue by lack of antivirals, dedicated antivirals, and no vaccine. It has been always challenged how to prevent it and how to treat it. So this story is a story that I will be narrating in the form of a gentleman who is a 65-year-old gentleman residing in Delhi, having a small family of 4 people and a well settled and a good daily routine. So he suddenly noticed that his son, who was 24 years old, developed high-grade fever associated with chills and rigor. He visited his family physician and he was started on some oral antibiotics, as we usually see what is there in the common practice, and laboratory investigations were sent. After 2 days, he developed significant cough. The son developed a significant cough with so much of weakness that he was unable to get up from the bed on its own. So this was what Mr. Roy noticed, and he asked his son, what is actually happening to you? He mentioned that he's feeling a little dizzy when he gets up. So he became really tensed and he checked for his blood pressure, which was on a lower side, around 104/72. He discussed the same with his family doctor and checked with the blood investigations what exactly is coming up there. So he was informed that the boy has tested positive for dengue, and other investigation. Usually what happens if somebody is testing positive for dengue, the first thing that comes in any common person mind is what is the platelet count. So he inquired about that and he looked that it is 1,32,000. He checked with his doctor and he reassured it is right now in a safer zone and he can continue with the home care. So he was also asked to repeat the routine investigation. So he was continuing at the home care, and on the 4th day of illness, his wife, Mr. Roy's wife, noticed that there is a reddish rash over the legs, and they have heard that these rashes in dengue could be a bad sign. So they got alerted. They also noticed that the skin is getting yellowish, the eyes also getting yellowish, and the boy was not accepting food at all. He was also complaining of nausea and vomiting. So they rushed to the hospital emergency. So at emergency, what doctors, when they examined, they mentioned that the blood pressure is on the lower side. The oxygen level is also low and the jaundice is there. So doctor mentioned that there is some fluid in the lungs and the abdomen, and also some abnormal sounds coming during chest auscultation. So they ordered a chest X-ray, they ordered an ultrasound abdomen. So this is the story I'm narrating from the patient side, what we actually see in our day-to-day practice when it comes to dengue, how it actually creates a chaos in the family of the patient who actually suffered from dengue. So all the blood investigations were sent, and the emergency, it was suggested that he requires an ICU admission because his blood saturation was low. His BP was on the lower side. So they were totally shattered. The family felt totally shattered, that they felt that they're going to lose the child from acute febrile illness, which is common like dengue. So the boy got admitted in ICU. They collected the reports of the blood investigation that were sent from emergency. And again, what they found that the platelets were very low. The blood reports was very alarming. A lot of the parameters were highlighted. Bilirubin was on a higher side. They discussed with the concerned team, and they found that the child is having dengue hepatitis along with a complicated dengue. So they asked for a transfusion, that the child is requiring a platelet transfusion. single donor platelet was required. He had a rare blood group. Again, that was a O negative. So this again is a common scenario that we see sometimes when somebody is requiring a platelet transfusion and having a rare blood group and requiring a SDP transfusion, which actually raises the platelet on a faster rate. Then it becomes a challenge to arrange the same blood group with a rare blood group. So after a long search of 6 hours, the family actually felt it is actually very long in this situation, the 6 hours. One of the family friend had this blood group. He donated the platelet and the SDP was transfused. Now the doctors we started all the possible supportive treatment, including oxygen supplementation. And so no antibiotic was actually given. Then the attendant asked the doctor that is any antibiotic is there that can be given in the dengue and the child can be saved. So the answer was no. So he and after so many years, of having dengue infection surrounding us, it is still we don't have actually the direct cure of the dengue virus. So gradually, but with having all faith in the doctors and the God, he gradually recovered after staying in 5 days in ICU, and he was shifted to ward. Again, the further supportive treatment was continued, and gradually he recovered and started accepting orally, was discharged from hospital. That was a big relief for the family. They took him back at home. Slowly he recovered his strength, following up with the doctor, and in the follow-up reports, gradually it was the LFTs were improved. The child was accepting orally good. So I must say that it was a big nightmare for the family who actually having a dengue patient, because when they come to us as a doctor, we have to say, we have to manage it, whatever the symptoms are saying. And you have to have a close watch regarding the warning signs. So we actually explain them what are the warning signs if we advise them at home care. So every physician has to take care of this, that the warning signs to the family attendant, they should know that if any abdominal pain is there, or a vomiting is there, or the patient is having some sort of dizziness, or the patient is having some sort of rash, because we know in dengue we can have sometime the normal maculopapular rash also, which is usually itchy. But if it is a bleeding rash, like if it's a petechial rash, if any rash is there, go to your doctor and get it examined, what kind of rash it is, whether he require admission or not. And it is not always the platelet value. I wanted to say this on this platform, that it is not always the platelet value that actually alarms. We actually see a lot of platelet dysfunction also in dengue. And sometimes with a higher value of dengue also, if there is a bleeding complication, we need to transfuse platelet, or sometimes even with a lower value of platelet, if the patient is otherwise stable, no bleeding complication, we just refrain from any transfusion and let the patient recover on its own. So this is important, and limitation in this case, we need to understand. We need a dedicated dengue vaccine for effective prevention. We right now don't have dedicated antiviral for this, and there's no role of antibiotics. So in dengue, there's no role of antibiotic. Please refrain from taking any medicine other than paracetamol to decrease your temperature. For fever, don't take any medicine other than paracetamol. No NSAIDs to be taken. No steroids are recommended. Thank you, Dr. Vidya. Yeah.
Thank you, Dr. Ankita. I think you have very, very clear, bold messages. No antibiotics in dengue, no steroids. Watch out for warning signs, and it's not just the platelet count, it's the platelet function and much more than just that. So I think it's time to wrap the session up, because we're running a little late. So we've got very good messages about prevention, looking at pneumococcal prevention, and about the dosing of antibiotics in pediatrics, starting with Dr. Vidya. Then we've had a lot about deadly fungus, Mucor. Mucor got very popular during during the COVID. That's when public realized Mucor, but all of us know how difficult it is to treat Mucor. So we had, I think, a very good talk on that as well, and importance of outbreaks, importance of history taking and identifying an appropriate disease, that's Nipah, and that was a very good case illustrated by Dr. Anup as well. So, and MDR not just in our gram negatives, MDRs in gonorrhea, something that's really alarming for public to know, and for doctors also to realize, and importance of using rapid diagnostic tests, and finally we have concluded with dengue. So I think it was a very great, very nice session. Thanks to all speakers out here. I think we just had some question from Dr. Raksha. It will be addressed, I think, separately on a webinar, because that itself is an entire topic of discussion. Thank you, Dr. Yamuna, Dr. Ghafoor. Thank you for this really wonderful, topic and platters of very nice, interesting topics.
Thank you so much, everyone, for having this wonderful evening compiled in 4 different file chats and looking into this no option webinar. I think all of us are convinced, and it's an eye opener to the medical community, to the public, and also to the media people, the where we are heading towards, and we are among one of them in the fight against antimicrobial resistance. We are very, as a part of AMR Trust, we are very happy to conduct such webinars, seminars, and workshops, which we would like to do as a free of cost for the better public and for a broader scope of coverage of people. For that, a few of our doctors were generous enough to donate to this trust. We would also take this opportunity to thank some of the pharmaceutical companies who has provided us with small donation like Sanofi, Galingen, Converge, Biotech, and Alnish. But since this trust has newly started and we have very minimal funds in order to support many more free academic, we have also requested donations from other pharmaceutical companies and also with our friends who would be generous enough to give this trust so that we could have similar programs conducted for an online platform to all of us to get more acquainted with all these topics. And I would thank all the panelists, the chairperson, for lending us or giving us this opportunity to involve them in such a serious talk and an eye-opener talk to all of us. Thank you so much, one and all.
Thank you. Thank you so much.